Kurang lebih itu yang ingin saya sampaikan. Kita bisa melakukan ini semua, tetap sehat, ya, tetap aman. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dr. Bambang atas paparannya, dan sebelum kita mulai ke sesi tanya jawab, kita akan memasuki materi kedua yang pada saat ini akan dibawakan oleh Principal Konsultan dari Joint Commission. Saya akan share sedikit materinya mengenai biografi beliau. Ya, untuk Dr. Eng. Hai Dr. Eng, are you there?
Yes, I'm here. Hello.
Okay, it's nice meeting you. So before we proceed with your session, I would like to introduce you to the audience and read a bit of your biography, if you don't mind.
Thank you. Yeah.
You're welcome. Oke, Dr. Eng adalah seorang perawat, registered nurse yang sangat berpengalaman. Beliau sudah berpengalaman 22 tahun di dalam dunia kesehatan, pelayanan kesehatan, 15 tahun di dalam infection control atau pengendalian infeksi, dan juga 10 tahun di bidang peningkatan mutu dan keselamatan pasien. Beliau lulus dari sekolah keperawatan di Australia, di Melbourne, kemudian mengambil master juga di Brisbane, Australia, di Griffith University, dan mengambil doktor juga di Sydney, Australia, di New South Wales. Kemudian professional experience dari beliau memang banyak berkontribusi atau banyak sekali pengalamannya di United Arab Emirates, ya. Dan kalau kita lihat, beliau pernah menjabat menjadi Corporate Nursing Quality Committee untuk SEHA, ya. Jadi SEHA itu kalau di sini mungkin seperti Kementerian Kesehatan, kira-kira seperti itu. Nah, selain jadi memang beliau banyak membantu dari mulai tertiary care, dari tingkat puskesmas sampai juga tingkat ke rumah sakit yang ada di pusat. Dan memang beliau pengalamannya di bidang infection control dan juga quality and patient safety sudah mendunia. Ya. Kemudian untuk sertifikasi yang beliau punya pada saat ini, beliau memang tersertifikasi untuk board di berbagai bidang, yaitu untuk infection control, kemudian healthcare quality, kemudian juga RPI Yellow Belt, dan juga beliau adalah fellow dari Association untuk profesional di dalam infection control dan epidemiology atau FAPIC. Ya. Beliau hari ini akan membawakan dua materi. Yang pertama adalah tata laksana COVID dari sisi pengendalian infeksi, dan yang kedua adalah bagaimana manajemen mengenai surcharge capacity, atau kalau ada influx atau ada pasien yang tiba-tiba banyak datang ke rumah sakit kita dan semuanya datang dengan COVID gitu ya. Jadi mungkin kita harus belajar bagaimana kita memanage pasien tersebut agar tidak terlantar dan mendapatkan pelayanan yang sesungguhnya atau yang diperlukan. Ya. Oke. Kira-kira itu biografi singkat dari Dr. Eng. Beliau akan bicara untuk dua sesi ini segera. Oke, Dr. Eng, you can start with your materials. I give you 1 hour for 2 of the sessions. So the floor is yours now.
Right. I'll share my screen right now.
Thank you.
Thank you, Dean. Okay. Can you see my screen?
Yes, clear.
Okay. All right,
Perfect.
Thank you.
So,
selamat siang. So, thank you for joining the webinar. So, I hope all of you are well. So, I'm going to start with the infection prevention and control strategy, priorities, operations considerations, and the roadmap during the COVID-19 new normal. So we know that right now, after the World Health Organization has declared the COVID-19 outbreak a global pandemic, we know our life changed. We're not like before anymore. So today, some countries are experiencing second or third wave, and some have not even gotten over the first wave, and some are moving towards the recovery phase. We're considering how to return to some of our normal activities while keeping everyone safe. So a new normal is actually a state through which economy and society settle following a crisis, when this differ from the situations that prevailed prior to the start of the crisis. So during this webinar, I'm going to list the strategy priority of the infection control activities and how to prevent and contain the COVID-19 cases, and also to outline the operation steps to consider when planning outpatient service continuations during COVID-19, and discuss the principle within the roadmap for resuming the elective surgery during the COVID-19. Okay. So let's start with the strategy priority of infection prevention control activities. So the goals of these activities in COVID-19 response is to support the maintenance of essential healthcare services by preventing the healthcare associated transmissions of severe acute respiratory syndromes, coronavirus 2, or we call it as SARS coronavirus 2, among the healthcare workers and the patients. So this requires a rapid identifications of suspected cases, immediate isolations, and referral for testing, safe clinical management, and adherence to the standard infection control precautions. So before getting started, I would like to give you a little bit overview about COVID-19. I think all of us, we know what is COVID-19, but just to give you a little bit of a background of what is that of COVID-19. So COVID-19 is actually caused by a newly emergent coronavirus, or SARS coronavirus 2. It's leading to the respiratory infections, including severe pneumonia. This virus is still evolving, and the most prescribed symptoms of the disease include fever, cough, shortness of breath, sore throat, diarrhea, myalgia, muscle ache, body ache, fatigue, and decreases in the sense of taste and smell are also reported. But elderly people or patients may represent differently than the younger populations, such as tiredness or confusions. So basically, COVID-19 is transmitted mainly via respiratory droplet, and respiratory droplets are produced when an infected person sneezes, cough, or talks. A person may get COVID-19 by touching the surface or objects that has the virus on it and then touch their own mouth, nose, or possibly their eyes. On October 5th, 2020, a scientific brief was released by the United States CDC, Center for Disease Control and Prevention, indicating then that pathogens that are mainly transmitted through droplet and contact transmission can sometimes also be spread via airborne transmissions under special circumstances. There are several well-documented examples in which SARS coronavirus 2 appear to have been transmitted over a long distances or times. So these transmission events appear uncommon and have typically involved the presence of an infectious person producing respiratory droplets for an extended time, such as around 30 minutes to multiple hours in an enclosed space. So enough virus was present in the space to cause infections in people who were more than 6 feet away or who passed through that space soon after the infectious person has left. Circumstances under which airborne transmissions of SARS coronavirus 2 appear to have occurred include enclosed spaces within which an infectious person either exposed susceptible people at the same time or to which susceptible people were exposed shortly after the infectious person had left the space. Second is prolonged exposures to respiratory particles, often generated with expiratory exertions such as shouting, singing, exercising that increase the concentrations of suspended respiratory droplets in the airspace, or inadequate ventilations or air handling that allowed a build-up of suspended small respiratory droplets and particles. However, some individuals with COVID-19 may lack any symptoms or asymptomatic, what we say, and COVID-19 may be transmitted by individuals who are infected but have no symptoms. So the strategy priority of infections prevention and control activities focus on 3 domains. Triage of patients upon initial encounter as a healthcare facilities for early identifications, preventions of transmissions during triage. This domain is intended for healthcare facilities that are receiving or are preparing to receive patients with suspected or confirmed COVID-19, and this includes healthcare facility provided either inpatients or outpatient services. It should be used to guide the implementations of procedures at triage that can be effective at preventing transmissions of any of this virus to the patients and healthcare workers. The second domain is limiting the entries of visitors with suspected COVID-19. The management of visitors is important to prevent the spread of such coronavirus to the healthcare facilities. The facilities should minimize the risk of transmissions to patients, to the visitors of the patients with suspected or confirmed COVID-19. So the risk of visitors introducing the viruses into the facilities increases as community transmission becomes well spread. Therefore, the facility should establish policy and procedures for managing, screening, educating, and training all visitors. The last domain is identifications and isolations of inpatients with suspected COVID-19. The development of healthcare-associated pneumonia is common, complications of hospitalizations, and it is important that clinicians maintain a high level of suspicions for COVID-19 when there is a compatible presentations. Because healthcare facilities often represent a gathering of the individuals at higher risk of infections and adverse outcome, the potential outbreak and harm to patients requires special effort to ensure any inpatients COVID-19 are identified and isolated promptly. Planning and coordinations of these activities should be conducted in collaborations with the emergency response officials in addition to the relevant public health officials, such as the Ministry of Health and subnational health offices. The upcoming slides that I'm going to discuss addresses specific detail on the domains and prioritized activities under the 4 different epidemiological scenarios of the COVID-19 transmissions within this domain. However, national and subnational public health authorities and the healthcare facility in all countries should be doing certain core activities to respond and prepare for the start of any activity regardless of the current state of COVID-19 transmission in the country. And this domain and prioritized activities should perhaps be adopted or adapted for any high consequence infectious disease scenario other than COVID-19. So let's start with the epidemiologic scenarios. There may be situations within a country whereby different geographic areas meet different scenario criteria. So Ministry of Health in coordinations with relevant stakeholders should consider the appropriateness and feasibility of applying a single set of prioritized infections prevention and control activities across the country matched to the most severe transmission scenario met versus implementing multiple sets of prioritized infections control activities in differently affected geographic units. Experience in this pandemic has shown that once a region is at scenario 2, where there are confirmed cases but no known community transmissions, aggressive testing strategies of undiagnosed respiratory infections may quickly reveal underlying community transmissions. This can result in a rapid progression to scenario 4, where there is widespread community transmission, sometimes within a little as a week. Thus, it's absolutely critical that countries prepare aggressively for future epidemiologic scenarios, even as they implement activities for the current situations. Ministry of Health and health facilities must act quickly once cases are identified to prevent and prepare for scenario 4. Let's start with the scenario 1, where there are no known cases in the countries. There are 3 domains in this scenario. For domain 1, triage as initial healthcare facility encounters. The facility should consider strengthening infection control during the routine triage to ensure standard precautions are used, such as hand hygiene, respiratory hygiene, and cough etiquette, and separations of infectious patients from other inpatients in the waiting areas or triage areas. It is also important to encourage clinicians to have a high suspicions for COVID-19 if seeing patients with symptoms on travel to a country with widespread community transmissions or with a known contact with the confirmed COVID-19 cases. These are because carrying symptomatic screening for COVID-19 and all healthcare facilities in a country without cases is prohibitively resource intensive, with a low return on investment and low likelihood on identifying the confirmed case. And limitations in lab testing can also make implementing systematic triage for COVID-19 at inpatient facilities in countries with no known cases very challenging. For limiting entries of healthcare workers with suspected COVID-19 in Domain 2, there should be a system to passively identify healthcare workers at inpatients and outpatients healthcare facilities who are ill. The healthcare worker should be reinforced messages about not coming to work if they are sick. This is because healthcare worker can spread COVID-19 in the healthcare facilities if they are an unknown case. For the third domain, the facilities should encourage staff to maintain a high suspicion for COVID-19 if seeing inpatients with compatible symptoms and no other clear etiology of illness, and inquire about any epidemiological links, such as travel history and contact with confirmed case. This is because systematic screening of inpatients is a resource-intensive activity and healthcare-associated pneumonia is common. However, it is important that clinicians maintain a high level of suspicions for COVID-19 where there is a compatible presentations and inquire about any epidemiologic links since this may be an early sign of introductions to the healthcare facilities. In scenario 2, there are confirmed cases but no known community transmissions. There are 4 domains within this scenario. For domain 1, triage as initial healthcare facilities encounter, the facility should consider strengthening infection prevention and control during routine triage as in scenario 1. It is also important to strengthen the linkages to contact tracing team to ensure contacts of known COVID-19 cases can access designated healthcare points if they become symptomatic in order to prevent known symptomatic contacts from showing up at the unprepared healthcare facilities. The facility should focus at this stage to ensure that symptomatic contacts of the confirmed cases are directed to present at healthcare facility prepared to receive them. This is the priority activities in order to prevent COVID-19 patients from arriving unrecognized at healthcare facilities. Carrying widespread systematic COVID-19 triage at healthcare facilities when cases are all epidemiologically linked is of lower priority. For limiting entry of healthcare and workers with suspected COVID-19 in COVID-19, it is the same as scenario 1. They should also have a system that enhances the detection. For example, policy for healthcare worker to call supervisor if they are sick or for supervisor to report if an employee does not come to work. This is because once cases are identified in a country, enhancing identifications of ill healthcare workers is necessary. For the third domain, it is also the same as scenario 1. This system should also, in addition, this system should also come with enhanced passive detections if visible, such as clinician reminders to consider COVID-19 in inpatients disseminated daily. This is because identifications of acute respiratory infections clusters within a healthcare facilities builds on the healthcare epidemiology that should be ongoing in the hospital to review the clusters of infections in time and space. During the COVID-19, special attention should be paid to cluster of acute respiratory infections in inpatients that might suggest healthcare-associated COVID-19 transmissions. In this scenario, we have another domain, that is the facility should implement policies to restrict visitors for patients with acute respiratory infections admitted to the healthcare facilities and passive detections of ill visitors, such as encouragement of visitors do not enter the facilities if they have an acute respiratory infections. This is because visitors to the healthcare facilities have the potential to introduce COVID-19, particularly when they are close contact of patients with suspected COVID-19. Scenario 3. They are confirmed cases with limited community transmissions, where limited amount of unlinked cases are identified in the communities. There are 4 domains within this scenario. So for domain 1, triage as initial healthcare facility encounter, the facility should consider strengthening the infections control routine during the routine triage as its scenario 1. It is also important to perform systematic screening of patients presenting to a healthcare facility to identify COVID-19 suspect cases guided by WHO or country-specific case definitions. This is because one, there is documented unlinked transmission in the country or geographic regions. The abilities to rely on identifying symptomatic contacts and sending to prepare facility become less efficacious as strategies to prevent and identify COVID-19 cases from entering a healthcare facilities. Systematic triage should be carried out widely in the facilities with access to lab testing, and this will allow the facilities to quickly confirm cases for the purposes of isolations. In area without a lab test capacities, systematic triage should be carried out only as facilities that are having a high likelihood of having cases and can consider using a highly specific case definitions. For domain 2, it is the same as in scenario 2 and consider implementing active screening in high-risk facilities to identify healthcare workers with acute respiratory infections prior to work. High-risk facilities should be defined by the local public health authorities, considering proximities to the facility or community with known COVID-19 cases, including those across the administrative or international borders, as well as prioritizing facilities seeing large number of patients at high risk of being COVID-19 case and where introductions will be highly disruptive, such as high referrals hospitals. This is because with growing transmissions comes high utility in expanding to active screening of healthcare workers, especially as community transmission widens and healthcare workers become increasingly likely to have contact with the cases outside the healthcare facility. For the third domain, it's also the same as scenario 2. And for the last domain, the facility should implement visitors restrictions, same as scenario 2. And the facility should also consider expanding to eliminating visitors for all inpatients and implementations of active screening of visitors with acute respiratory infections with no entry for ill visitors. In scenario 4, there are confirmed cases with widespread community transmissions where many unlinked cases identified in the communities. There are 4 domains in these scenarios. For domain 1, triage as initial healthcare facility encounter, the facility should consider strengthening the infection control during the routine triage as in scenario 3. This is because the widespread community transmissions, the likelihood of finding positive cases at triage is highest, and therefore the highest priority should be placed on implementing functional triage as initial healthcare facility encounter. This will be challenging in places without access to the lab services. For domain 2, there should be active screening to identify ill healthcare workers prior to work. This is because with widespread community transmissions and in prior outbreaks of emerging infectious diseases, healthcare workers are at high risk for becoming cases. In this scenario, healthcare workers should be actively screened prior to shifts to avoid further transmission of COVID-19 if ill. For the third domain, it is the same as scenario 2 with considerations of screening of inpatients for COVID-19 if resources allowed. This is because with increased community transmissions, the likelihood of missing patients with COVID-19 at triage becomes more likely, and thus the likelihood of healthcare-associated transmissions. Therefore, increased attention to single cases of possible COVID-19 arising among inpatients should be prioritized. For the last domain, the facility should implement active screening of all visitors to the hospital for illness consistent with COVID-19 with no admissions for sick visitors at all. Regardless of the epidemiologic scenario in a country, an inpatient facility is housing suspected or confirmed COVID-19 cases, specific isolation precautions should apply. These are indicated by the World Health Organizations, and facility with confirmed cases may need to carry out prioritized activities from other epidemiologic scenarios, even those scenarios do not represent the countrywide COVID-19 situations. This could include, for instance, a hospital with confirmed COVID-19 cases, choosing to conduct active screening of healthcare workers for signs and symptoms of COVID-19, despite this is not being listed under the routine priority activities in that country epidemiologic scenario. For example, develop a plans to carry out prioritized infections prevention and control activities for prevention and containment of COVID-19 cases by epidemiologic scenario in order to prevent the spread of the disease within the facilities. Develop a standard operating procedures for environmental cleaning and disinfection procedures, particularly for the triage and operation and isolation area where suspected or confirmed COVID-19 patients will be placed. The third is developing a staffing plan to adequately staff isolation area and consider whether cohorting staff is feasible. The next is develop a contingency plan for PPE shortages and other IPC infection prevention and control consumable, such as alcohol-based hand rub shortages, in cooperation with the national and subnational public health authorities. The last activities is to develop a communications plans to ensure adequate internal and external communications regarding COVID-19. Educate healthcare worker is also another important core activities and on the sign and symptom of COVID-19 signs, symptoms, and require IPC protocols. The next is develop policies for visitors restrictions, such as restrict visitors who are sick with COVID-19. Develop a policy to identify and risk stratify healthcare workers exposed to the COVID-19 cases and monitor their movement and return to work. The last is to establish a communication channel between healthcare facilities and public health authorities who can facilitate the linkages with lab testing and epidemiology or contact tracing. We move on now. I've finished the core activities, the strategy priorities. So we move on now to the strategies for implementations of infection control guidance for the outpatient care settings. So the purpose of infection prevention and control in outpatient setting during the COVID-19 is to minimize the disease transmissions to the patients and healthcare workers, to identify a person with signs and symptoms of suspect COVID-19 for rapid isolations and triage, and to maintain essential health services. There are 4 operational steps to consider when planning outpatient service continuations in the context of COVID-19. The first is to modify the service delivery through the infections control administrative and engineering controls to maximize a patient's and healthcare workers' safety. The second is to prepare the staff and facilities to receive the patients with suspected and confirmed COVID-19. The third is to implement a controls to rapidly identify and isolate patients with suspected COVID-19. And the last key considerations is to implement infection prevention control for alternate care sites and non-facility based care. All these steps will be elaborated in the coming slide. Let's start with the first step. Modifications to the outpatient operations, such as infections prevention and control administrative control and modifications to the physical layout of the facilities, such as infections prevention and control engineering controls, are the important ways to reduce crowding and mixing of potentially infectious and non-infectious patients as the facilities and preventing transmissions of SARS coronavirus 2. Coordinations with the local public health authorities is helpful to expand strategy available to individual facilities, such as identifying alternate care sites for essential health services. Additionally, in community with widespread community transmissions of COVID-19, implementing source control of all patients, visitors, and healthcare workers at the clinics through the wearing of wear masks can also reduce the transmission of this virus. The second steps. Despite modifications to the outpatient operations to reduce the risk of COVID-19 transmissions at the facilities, patients with possible COVID-19 will still be seen. Optimizing preparedness of the facilities to receive patients with symptoms consistent with COVID-19 can help limit the risk of exposure to the patient and the healthcare workers. Facility leadership and the infection control focal point should review the international infection control guidance from the professional organizations such as World Health Organization IPC guidance during the healthcare when COVID-19 is suspected, and mostly to also follow the national international infection control guidance to prepare facilities to safely triage and manage patients with respiratory illness or any high consequence infectious disease, including COVID-19. The third step is, as recommended by the World Health Organizations, all patients arriving at the outpatient facilities require screening to rapidly identify and separate patients with suspected COVID-19. The IPC focal point at the facilities, under the authority of the facilities leadership, should oversee implementations of screening to prevent spread of such coronavirus 2 at these facilities. The sorting out and classifications of patients to determine the priorities of need and proper place of treatment. During the infectious disease outbreak, triage is particularly important to separate patients likely to be infected with pathogens are confirmed. The triage procedure is developed in the context of COVID-19 pandemic and does not replace any routine clinical triage already in place in healthcare facilities to categorize patients into different urgency categories. Effective triage can prevent transmission of such coronavirus to the patients and healthcare workers. The last steps. To minimize the risk of COVID-19 transmissions, the use of alternate care sites or non-facility-based models of healthcare delivery may be considered to separate the healthy patients in need of essential health services from patients seeking care for acute illness. Alternate care sites include community-based locations such as a school or community halls, and that may be temporarily out of use during the local mitigation measures. Such sites offer the benefit of space to allow appropriate physical distancing of healthcare workers and patients. However, since these sites are not primarily intended for the delivery of healthcare, their structures might pose a challenge for outpatient services that require physical exams and are best actually to be used to deliver single-purpose care such as drug pickups, immunizations, or well child visits. So similarly, non-facility-based care, which include outreach services to people homes or mobile services, help minimizing the crowding at the healthcare facility while maintaining essential health services. So now I have discussed the 4 operation steps for implementations of the infection guidance for the outpatient care setting. We start with the roadmap for elective surgeries. Any decisions on whether to operate on patients should not be based on the patient's COVID-19 status, but on the need, such as trauma, emergency, the risk and benefit of the surgery, whether the patient is the life-threatening outcomes or patient's harm, if the patient will be harmed if surgery is delayed, and patient clinical conditions as well. In the context of COVID-19, every surgical procedure may entail risks for both patients and healthcare workers. As part of their routine clinical practice, healthcare workers should apply standard precautions and assess potential risks of exposure to infectious material. These precautions should include engineering controls that reduce exposure to infectious material, administrative control, and PPE used. In response to the COVID-19 pandemic, the World Health Organization's Center for Disease Control and Prevention and many medical specialties such as the U.S. Surgeon General, the American College of Surgeons, and American Society of Anesthesiologists recommended the interim cancellations of surgical procedures. Physicians and healthcare organizations throughout the world has responded appropriately and canceled non-essential cases across the countries. Many patients have had their needed but not essential surgeries postponed due to the pandemic. While this pandemic is still ongoing, the pent-up patients' demand for surgical procedures care may be huge, and healthcare organizations, physicians, and nurses must be prepared to meet this demand. Facility readiness to resume elective surgery will vary by geographic locations and by regions or by countries. There are 7 principles with the roadmap for resuming elective surgery in the healthcare facilities. So I'm going them each one by each one in the upcoming slides. The first principle is the timing for reopening of elective surgery. There should be a sustained reductions in the rate of new COVID-19 cases in the relevant geographic area for at least 14 days before resumptions of elective surgical procedure. Any resumptions should be authorized by the appropriate national or local health authorities. Facilities are safely able to treat all patients requiring hospitalizations without resorting to crisis standard of care. The facility should have appropriate number of ICU and non-ICU beds, PPE, ventilators, medications, anesthetics, and all medical surgical supplies. The facility should have available numbers of trained and educated staff appropriate to the planned surgical procedures, patient populations, and facility resources. Given the known evidence supporting healthcare worker fatigue and the impact of stress, the facility should ensure its capabilities to perform planned procedures without compromising patient safety or staff safety and well-being. The second principle, facilities should use available testing to protect patients and staff safety whenever possible and should implement a policy addressing requirements and frequency for the testing. Facility COVID-19 testing policies should account for 4 elements. The first element is availability, accuracy, and current evidence regarding the test, including the turnaround time for the test results. Patient testing policy is a second element, and it should include frequency and timing considerations to provide useful pre-operative information as to COVID-19 status of surgical patients. If such testing is not available, the organization should consider a policy that addresses evidence-based infections prevention and control, technique, access control, workflow, and distancing processes to create a safe environment in which elective surgery can occur. If there is uncertainties about the patient's COVID-19 status, the PPE appropriate for the clinical task should be provided for the surgical team. The third element is indications and availability for the healthcare worker testing. And the last element is how a facility will respond to suspected and confirmed COVID-19 patients and healthcare workers. The third principle, PPE. Facilities should not resume elective surgical procedures until they have adequate PPE and medical surgical supplies appropriate to the numbers and type of procedures to be performed. Organizations' policies for PPE should account for 3 elements listed in this slide. These elements are adequacy of available PPE, including the supplies required for potential resurgence of COVID-19 cases. The second is staff training on the proper use of PPE according to the non-crisis or conventional level evidence-based standard of care. And the last element is developing policies for the conservation of PPE as well as policies for any extended use or reuse of PPE as per evidence-based guidance or according to your local regulations. The fourth principle is case prioritizations and scheduling. Facilities should establish a prioritization policy committees consisting of surgery, anesthesia, and nursing leadership to develop a prioritization strategy appropriate to the immediate patient needs. Prioritization policies committee strategy decisions to address case scheduling and prioritization and should account for 8 elements listed in this slide. List of the previously cancelled and postponed cases. Use of objective priority scoring, such as medically necessary time-sensitive prioritizations process. Specialties prioritization, such as organ transplant, cardiac trauma. Strategy for allocating daytime for procedure time, such as block time, prioritizations of case type, such as potential cancel, leaving-related organ transplants. The fifth one is identifications of essential healthcare workers, healthcare providers, and medical device representative per procedures. Number 6 is strategy for phase opening of operations room, and this includes identifying capacity goal prior to resuming, for example, 25% versus 50% outpatients or ambulatory cases start surgery first, followed by inpatient surgery. However, this will require more personnel and material. Number 7 is strategy for incoming OR or procedure time availability, such as extended hours before the weekends. It is also important to address issues associated with increased procedure volumes to ensure primary personnel availability commensurate with increased volume and hours, such as surgeries, anesthesia, nursing, housekeeping, engineering, and sterile processing. To also ensure adjuncts personnel availability, such as pathology and radiologies, ensure supply availability for planned procedures such as anesthesia, drugs, procedures-related medications, sutures, disposable and non-disposable surgical instruments. Ensure adequate availability of inpatients' hospital bed and ICU bed, ventilators for the expected post-operative care, and it's also important to also ensure adequate staff training. The fifth principle is post-COVID-19 issue for the 5 phases of surgical care. Organizations' policy should consider the 5 phases when adopting policies specific to COVID-19 and the postponement of surgical scheduling. Phase 1, preoperative. The facilities can adopt guidelines for preoperative assessment process and patient's readiness for the surgery that can be coordinated by the preoperative assessment services. The second guideline that addresses the timing or reassessing patient's health status can also be developed or adopted. During this phase, consider advanced directive discussions with the surgeon, especially patients who are older adults, frail, or post-COVID-19, and assess for need for post-acute care facility stays and address before procedures. For phase 2 immediate preoperative, guideline for pre-procedures interval evaluation since COVID-19 related postponement should be developed. In phase 2, it is also important to assess the need for revisions of nursing, anesthesia surgery, checklists regarding COVID-19. In phase 3 intraoperative, there is a need to assess the need for revisions of pre-anesthetics and pre-surgical timeout components. In this phase, guidelines can be developed to address who is present during the intubations and extubations, PPE use and presence of non-essentials personnel, for example, guidelines for who is present during the intubations and extubations, guideline for PPE use, guideline for the presence of non-essential personnel, including the students. Phase 4 is a post-operative phase that addresses the importance to adhere to the standardized evidence-based enhanced recovery after surgery protocols to optimize the length of stay, efficiency, and decrease complications. Phase 5 is about the post-discharge care planning that should address post-acute care facilities availability and PAC facilities safety related to COVID-19 and non-COVID-19 issues, home settings, where ideally patients should be discharged home and not to the nursing home, as higher rates of COVID-19 may exist in these facilities. The sixth principle is collections and management of data. Facilities should re-evaluate and reassess the policies and procedures frequently based on the COVID-19 related data, resources, testing, and other clinical informations. Facilities should also collect and utilize relevant facilities data, enhanced by data from local authorities and government agencies as available. The data include COVID-19's numbers such as testing, availability of inpatients and ICU beds, intubated OR procedure cases, new cases, death, locations, tracking, isolation, and quarantine policy. The second element is facility beds, PPE, ICU ventilator availabilities. And last of the elements is about quality of care metrics such as mortalities, complications, readmissions, errors, near misses, and others, especially in the context of increased volume. The last element is COVID-19 related safety and risk mitigation surrounding this pandemic. Facilities should have and implement a physical distancing policies for patients, healthcare workers, and patients, visitors in non-restricted areas in the facilities for community isolation practices. Each facility physical distancing policy should account for the current, local, and national recommendations, the number of persons that accompany the procedure patients to the facilities, and whether visitors in the pre-procedures area should be further restricted. As healthcare facility begins to relax restrictions on the healthcare services provided to the patients, such as restarting the elective surgeries in according to the guidance from the local officials, there are emergency management key principle strategy that remain in place as part of the ongoing to COVID-19 pandemic and future emergencies. Most infection control recommendations in these sessions are not new. The infection control priorities, operations, considerations for outpatients, and roadmap have been developed to help contain and prevent any consequence infection disease outbreak in the healthcare facilities and facilitate implementations of the WHO technical guidance on infection prevention and control activities for the countries. So I'll move on to the second one.
Oke, setelah Dr. Eng nanti memberikan sesi yang kedua, kita akan buka sesi tanya jawab. So please, Dr. Eng, continue with your second session.
All right, sure. Right, now we will go on to we'll proceed with the optimizing search capacity during the COVID-19 response. The variations in the admissions rates during the COVID-19 pandemic indicate that business as usual service delivery approaches are not sufficient to respond one cluster of cases or widespread community transmission is registered, and such capacity will be needed. While aggressive measures to find, isolate, test, treat, and trace are the best way to stop the spread of this virus, public health interventions to flatten the curve may slow the transmissions and mitigate the peak capacity need. So monitoring studies points to the impact of non-pharmaceutical interventions such as physical distancing, universal masking, school and university closures, banning of mass gatherings, and remaining indoors on spreading the number of cases over a longer periods to give health system the opportunity they need to cope with the caseloads. These models have helped to reinforce the message about the implementation of such measures alongside with widespread testing to detect cases and break the chain of transmissions. In addition to this measure, phase plans for creating such capacity in the organizations will help to respond to the COVID-19 while maintaining the essential services. Such capacity is the ability of a healthcare system to manage a sudden and unexpected influx of patients in a disaster or emergencies. Such capacity can be created from intrinsic and extrinsic resources. The intrinsics covered all local resources that can be used for the response, while the extrinsics involve leveraging the resources from outside the affected area across the geographic and across the specialty. Creating the surge capacities involve a comprehensive approach linking the 4 S of surge capacity, which are space, staff, supplies, and system, as shown in this slide. The 4 S of surge are independent factors in determining organizational capacities. When one factor cannot support the demands of another, it becomes the rate limiting factors. It is crucial to understand the specific need presented by COVID-19, know which factor is your limit, and consider a rationing plan to provide guidance for different scenarios. In some cases, the need for ICU bed for critical supplies such as ventilators, medicines, medical gases, staff skills, and PPE impacted the abilities to adequately respond to a surge. It is important to determine how routinely a specific hospital meet capacity and identify where to shift intake to avoid capacity issues. The 4 S will be discussed in the next slide. Space or structures covers hospital and beds, but also the facility that are either already available in those settings or which could be equipped for specific emergency needs. For example, areas for appropriate triage and cohort units with adequate air ventilations. Space also includes the potential for repurposing or requisitioning of the structures beyond the hospital setting to provide access patients number, such as community hall, hotel, etc. Staff is about ensuring enough appropriately skilled and supervised healthcare workers during the emergency. In addition to the number of healthcare workers needed and where healthcare needed can be added or repurposed from, such capacity must account for varying degrees of healthcare worker need, specialization needed, and crucially analysis of potential shortfalls. Potential staff shortfalls can occur for reasons including non-attendance due to stress, overwork, mental health concerns, and prospective sickness. In the context of COVID-19, healthcare workers may have concern for their own health and in turn for their own families. Sufficient rest and recuperations for healthcare workers as well as their availability to work need to be accounted for any such capacity calculations. Supply relates to the store availability of specific equipments for emergency deployment, both for patient care and healthcare worker safety. In the context of COVID-19, this covers different types of units and beds, intubation equipments, mechanical ventilators, and essential medications, in particular supplies of oxygen, PPE, etc. Most patients hospitalized with severe disease will need oxygens, and a smaller proportions will require ventilations. Insufficient supplies or procedures to procure them quickly will severely hinder any such response. Healthcare workers need to be trained in the use of applications of supplies, and for some equipment, specialists may be required. System refer to the modes of working to ensure ongoing and proactive coordinations for optimal surge capacity response. These modes of working ensure that integrated policies and procedures exist and activated to develop optimized sustainable surge capacities. Systems are not just the glue that bind all the surge elements together, but are also what ensures that these elements work together in practice. So systems cover decision-making, communications, continuity of operations, and supply chain management, among others, and must be based on shared values, including teamwork and mutual respect across the settings. Evidence gathered in previous emergency indicates that poor management of system during surge capacities planning and the response have been the weak point of the 4 S, resulting in underutilizations of available surge capacity resources during the emergency situations. We'll now discuss the recommendations and strategic actions to activate the surge capacity in line with these 4 S, drawing on past experiences in emergency and on the emergent experience of 13 countries in the COVID-19 response. I'll go into detail and example of each of them. There are 4 strategic actions to activate the surge capacities as shown in these slides. The actions are create and activate a stepwise plan to expand physical spaces to care for COVID-19 patients, respecting infection prevention and control protocols. The second is to identify the health workforce available for surge capacity demand and repurpose and upscale for rapid deployment to meet the surge capacity needs. The third is to ensure adequate supplies to support the surge in demand. And the last action is to establish systems to manage and align policy to meet the surge in demand. Strategic Action 1 have 8 key components. The first is to estimate the surge capacity needed for acute and intensive care. The second is to develop criteria to designate hospitals to receive COVID-19 patients. The third is to regulate patients' flow in designated hospital to protect both healthcare workers and other patients. The fourth is progressively postpone all but the most urgent elective surgery and internally repurpose space and staff. The fifth is accelerate discharge and define stricter criteria for admissions to essential health services to create additional surge capacity for COVID-19 patients. The sixth is to optimize the current delivery platform and develop alternative delivery platform to essential health services. These include developing remote work solutions, boosting the home hospitalizations program, and rapidly scaling up existing e-health strategy. The seventh component is purchase or otherwise acquire additional capacity from the domestic private health sectors. And the last component is to repurpose non-medical facilities or facilities of opportunities and establish temporary medical facilities to accommodate peak demand. So let's start with the first component. The surge capacity needed can vary significantly depending on the success of public health and physical distancing measures to slow the transmission and the social demographic characteristic of the affected populations. The World Health Organization has developed a set of surge calculators to facilitate the surge planning for the policy makers at the national, regional, and facility levels. These calculators can be complemented with a sophisticated human resources for health surge planning, a plan appropriate to the national, regional, and facility level planner that consider different types of healthcare worker with different levels of competencies. There are 3 surge planning tools as shown in this slide. Adapt surge planning support tool, which allow to focus on the surge planning information such as the number of beds required, the dates of predicted bed shortages, and the detailed human resources needed. The second tool is Health Workforce Estimator tool. This can be used to estimate the required number of each type of healthcare worker based on the target number of mild, moderate, severe, and critical patients per day, while the contact tracing tool can be used to required contact tracing workforce based on the average peak infections reporting rates over follow-up defined periods. This tool also provides an analysis of the throughput of mild, moderate, severe, and critical patients in multiple facilities and highlights workforce gap for each of the healthcare workers. The last one tool is Essential Supplies Forecasting tool, which helps to manage essential supplies. It provides specific focus output, including detailed quantifications of equipment such as PPE, diagnostics, biomedical equipment, drugs, and consumables. It also provides quantifications for inpatient beds, tests for mild, suspected, severe, and critical cases, some output on COVID-19 cases, and health workforce requirement, including community health workers, in an aggregated format. These two are available in the WHO website, and I'll be also included in this slide. The second component is develop criteria to designate hospital to receive COVID-19 patients. During the planning phase, it's important to establish minimum criteria for the safe care of COVID-19 patients based on the clinical management guideline, the infection prevention and control guidance, and the designations of appropriate COVID-19 unit where space is an issue. Some hospital has designated COVID-19 unit and COVID-19 plus unit. For example, which unit converted to COVID-19 unit and additional COVID-19 patients in a non-acute inpatients unit. A phase plan is likely to be needed to reflect the progressive expansions of the range of designated hospital as the number of cases progressed. The designated hospital should be assessed for readiness to receive the COVID-19 patients. The World Health Organization has published a rapid hospital readiness checklist containing 12 key elements to facilitate this. And the link to the checklist is included in this slide as well. The third component is to regulate patients' flow in designated hospital to protect both patient, healthcare workers, and other patients. To protect the patients and healthcare workers, designated hospitals should retain all the patients and logistic circuits such as medicines, medical devices, consumables in the different care areas managed from the hospitals. Implementations of infection prevention and control must remain a priority to ensure the safest possible environment for all patients and healthcare workers. All areas of the facility should implement administrative control, engineering controls, and enables an environment for the rational use of PPE. The increasing numbers of patients who will require that most COVID-19 designated hospital dynamically redefine the exclusive COVID-19 areas. The implementations of a color system can be useful. For instance, red for COVID-19 areas, yellow for transition areas, and green for non-COVID-19 safe areas. In the emergency department, the definitions of potential COVID-19 patient area need to be considered. Some countries have set up field hospitals to avoid mixing of COVID-19 patients and other patients. Other countries are managing all mild and low to moderate risk patients with confirmed case diseases, either in designated community facilities such as community hall, hotel, etc., with access to a rapid health services, while dedicated COVID-19 health posts, telemedicine, or at home according to the international guideline and national or subnational capacities. Suspected COVID-19 patients who are waiting for the lab results should be placed in adequately ventilated single rooms. If single rooms are not available, suspected patients can be cohorted with other suspected cases in adequately ventilated rooms. All lab confirmed cases should be placed in adequately ventilated single room or cohorted with other confirmed cases. The ancillary exam areas, such as radiologists, need to be programmed for specific COVID-19 time slots to reduce the opportunities for healthcare associated transmissions and increasing productivity as well. The fourth component is to progressively postpone all but the most urgent elective surgery and internally repurpose space and staff. This can release significant numbers of beds and healthcare workers and enable repurposing operating theaters, recovery rooms, and other hospital facilities while maintaining operability to maintain the healthcare services. The release of elective capacity can also allow operating theater equipments to be repurposed to support the ventilated patients while paying attention to infection prevention and control. For those patients that will need planned surgery, create an elective only site, optimize the operating theater's capacity by extending hours, including weekend use. Healthcare workers who were previously working in an elective surgery setting will need to be released to work in a new location and will need inductions and top-up training to enable them to provide adequate medical care to the patients. The fifth component is accelerate discharge and define stricter criteria for admissions to essential health services to create additional surge capacity for COVID-19 patients. More rapid discharge of patients with non-COVID-19 health conditions will be necessary, and standardized protocols to identify cases where there is a good clinical reasons for the patients to be in the hospital can be used to support this. Improved discharges will require improvements in internal decision-making processes, such as more frequent unit rounds, logistics like requesting transport, arrangement for medicines, and appliances to be available on discharge, as well as coordinations with the community services. requisitioning other facilities nearby, such as hotel community centers, and converting these facilities for patients who have been discharged early could be considered. This is an example of situations in which close collaborations with public health and social services is crucial and ties into the system elements of the surge capacity response. For patients hospitalized for social rather than health reasons, align the hospital and social services to work together to actively find community solutions to assure adequate care for these patients. The adoptions of discharge to assess model can assist in ensuring the rapid and safe transfer of patients to other care modalities. Financial barriers need to be considered and potentially addressed. For example, the cost of home care versus residential care. Some countries or healthcare organizations hospitalize patients for diagnostic, minor surgery, or follow-up, and all admission need to be carefully assessed, and other solutions should be considered using different approaches in collaborations with the other healthcare organizations. The sixth component is optimizing current delivery platform and develop the alternative delivery platform for essential health services, like developing a remote work solutions, boosting the home hospitalizations programs, and rapidly scaling up existing e-health strategies. During the COVID-19 pandemic, the capability of hospital and primary care system to provide telephone, video, or web-based consultations has rapidly stepped up, so no patient need to attend the hospital unless necessary. Some routine outpatient care has continued through this route. Countries with existing e-prescription system expand their use without physical visits, ensure the automatic renewal of prescription for chronic patients, and extending the periodicity of needed renewals. The COVID-19 epidemic enhances the development of home treatment for acute care program where there exists, releasing the acute hospital bed and reducing the risk of healthcare-associated infections. A critical and enabling factor is to ensure that purchasing contracts and provider payment mechanism rapidly adjust to facilitate these new modalities. It's important to ensure telemedicine or broadband system have sufficient bandwidth and security provisions to deal with the increased level of work. Additional support through user-friendly guides will be needed to ensure the elderly are still able to use the alternative model of care, particularly where technical literacy may be required. The 7 components. The extra resources secured from the private sector can be used to expand the capacity to manage and treat COVID-19 cases and to deliver other urgent treatment. In the early stages of the outbreak, additional capacity was sourced from the private sector in some countries to ensure that elective operations such as thyroid, prostate, hernia, or gynecological surgeries were completed before the predicted surge in demand. During the early stage of the surge, some private hospitals and clinics postponed non-urgent interventions and operations to free up capacity. It is important to negotiate with the private sectors to ensure they make available the capacity that has been freed up. Ensuring the reimbursement for this is at cost so that no profits are made and that the financial sustainability of the response is secured. Alternatively, consider using emergency legislations to enable national or regional governments to take over the management of needed facilities and surge services, ensuring these are cost-effective and fully available for the national response effort. The last component is repurpose the non-medical facility of opportunity and establish temporary medical facility to accommodate the peak demand. For time of extreme surge in demand, repurposing non-healthcare facility can be considered. This facility can be used for clinical care of mild cases or severe cases when they have been discharged after the resolutions of symptoms, follow-up of mild, moderate cases, and diagnostics. This facility will need to be assessed to ensure they are suitable for infectious patients regarding water, sanitation, and hygiene requirement and heating options. This facility can be used for aftercare for other inpatients to release capacity in main hospitals. In addition, setting up new temporary medical facilities such as field hospitals can be considered to increase the hospital capacities. This facility can be operated by the healthcare workers and can perform a variety of functions ranging from emergency care and triage to hospitalizations of severe case and intensive care. So here are the country experiences to create the surge capacity for space, postponing or elective non-urgent procedures, medical appointment, and ancillary exam and non-essential activities such as training or scientific sessions for healthcare professionals, reducing or eliminating bed occupied by delayed discharge patients and patients with mild conditions, removing the financial obstacles to discharge for patients requiring ongoing nursing or social care, repurposing the operating and recovery room into ICUs, and repurposing hospital spaces routinely used for others to serve as emergency unit for patients with mild symptoms. Establishing drive-through diagnostic sites in the community to release pressure from the healthcare facilities. Developing remote work solutions and enhancing existing e-health strategy or telehealth such as phone and video call e-prescriptions. Boosting the strategies to provide medicine at home for chronic patients, reducing the hospital workloads. Increasing the health phone line capacities and the COVID-19 algorithms to control hospital services demand. Establishing CAM hospital with a variety of purposes, including emergency care and triage, ICU and semi-ICU bed, recovery bed for patients who cannot be discharged, make all private and independent hospital beds available to the public system where relevant. Repurposing non-medical settings for isolations, follow-up of moderate cases for ICU bed and diagnostic service such as imaging, purchasing from the private sectors, allowing regions to take over management of private health services as needed, or armed force hospital make available to treat the general populations, and transferring patients to the other region or neighboring countries as appropriate. Strategic actions 2 is to identify the healthcare workforce available for the surge capacity demand and repurpose the upscale of rapid deployment to meet the surge capacity need. There are 5 components for these actions. So I'm going to go through them, each one, the 5 of them in the coming slide. The first component is to mobilize temporary health workforce to enable surge capacities. Planning additional healthcare workers, a requirement over time and across the regions, is an important first step in mobilizing surge capacities. There are a range of options for mobilizing healthcare workers, including expanding the hours of part-time staff, cross-regional mobility, repurposing staff, etc. These options can be found in the World Health Organization's technical guidance on maintaining the delivery essential healthcare service while mobilizing the healthcare force for the COVID-19 response. It is essential to provide a rapid training to upskill the healthcare worker to carry out new tasks, including diagnostic, triage, clinical management, responsibility, and infection prevention and control, and that healthcare workers are appropriately supervised in the performing of these tasks. To enable rapid mobilizations of health workforce, it's important to ensure that mobilized healthcare workers have the legal rights to work and are properly indemnified to protect them from risk of litigations in the normal conduct of the
Dr. Earl, are you there? Dr. Earl? Oke. Kita tunggu sebentar dari Dr. Ang, mungkin ada koneksinya kurang baik atau terputus. Oke, sambil menunggu mungkin bisa kita buka dulu untuk...
Can you hear me?
Yes. Oh, you're back.
I don't know what happened.
Okay.
Is
Please
that okay?
continue. It's okay. Can you share screen now?
Yeah, I will share the screen. I just reconnect back. I don't know what happened.
Okay.
Yeah, right. Okay, right. Okay, can you see my screen now?
Yes.
Okay, right.
Perfect.
Right. So the second component is to map and expand the pool of critical care healthcare workers. The availability of sufficient number of fully trained critical care and ICU healthcare workers may become a significant constraint. Options to mitigate this include CCU or ICU trained staff currently working in other settings, including as pediatric infectious disease specialists in critical care medicines, to be identified from both public and private sectors and redeployed with appropriate refresher training, and consider options to shift care requirement across the scale boundaries. This will require the identifications of other healthcare workers who can undergo a rapid period of training to support the full trained healthcare worker, therefore increasing the number of patients this healthcare worker can support. The third component is to upskill the healthcare workers at the front line of the COVID-19 response. Whole health workforce in the communities and hospital-based services should be provided with the COVID-19 training online or in designated community training facilities. So rapid training mechanism and job aids facilitate appropriate decision-making in key capacities, including diagnostic triage, clinical responsibilities, and essential infection prevention and control. Is crucial to mobilize adequately supported supervision structures and capacity to reinforce and support rapidly acquired knowledge and skill. The third component is about the always ensure safety and protections of healthcare workers in the front line of healthcare services delivery through the implementations of infection control. Supply chain was among the most significant challenges to responding to COVID-19. A report outlines serious shortages of PPE in at least 63 countries. Healthcare systems across the country around the world are face to face with that harsh realities, as many of the largest healthcare suppliers are unable to fully meet the growing global demand of the PPE for healthcare workers. So although the use of PPE is a more visible control used to prevent and control the spread of infection, it is the last and weakest of the hierarchy of the infection prevention and control measures, and should not be relied on as a primary infection control strategies. So in the absence of effective administrative and engineering control, PPE has a limited benefit. It is vital to maximally protect healthcare workers from infections in their frontline duties through ensuring implementations of administrative controls, engineering controls, and enable an environment for the rational use of PPE, adequately use of PPE, and the rollout aggressive testing. It is definitely important to secure and allocate PPE for the health workforce, providing frontline services in the hospital and community are ensure that the health workforce is properly trained in terms of rational use and disposal of PPE. So critical interventions such as ICU bed and mechanical ventilators must be made available for healthcare workers and other supporting the response in terms of service and infrastructures, whose training make them indispensable. Considering reassignment of the healthcare worker in the high-risk categories for COVID-19 complications to tasks or settings that reduce the risk of exposures, while releasing other healthcare workers less at risk to provide care for patients with COVID-19. To conserve the PPE, considering reduced visits to non-acute COVID-19 patients, with healthcare workers checking up on them using the telephone, mobile phone, or other non-face-to-face means. The fourth component is to take care of the mental health needs of the frontline healthcare workers. It is important to ensure healthcare workers receive appropriate hours and enforce rest periods. Some health organizations put in place optional accommodations arrangement for hospital-based healthcare workers to reduce time spent traveling to and from home and protect healthcare workers' family from indirect exposure. And they have also identified domestic support measures such as transport, childcare, care of ill or disabled family members with the provisions for young family with both parents are healthcare workers that could enhance staff flexibility for the shift work. Develop a buddy system so that healthcare workers always have a colleague with whom they can talk frankly and share concern, and set up a dedicated mental health hotline for healthcare workers. And given the strain on hospital-based healthcare worker in potentially dedicated on-site counseling service for healthcare worker in which social and mental healthcare worker and advisor from the civil societies and other bodies can support here. This slide shows the country experienced to create such capacity for the staff. Relaxing or modifying hiring procedures to quickly recruit healthcare workers, which include allowing the final year's medical and nursing students to enter the practice early, including medical doctors training to become specialists, recruiting retired healthcare worker in low-risk settings, and mobilizing and recruiting all healthcare workers from the military forces. Establishing a COVID-19 job bank or equivalents for volunteers across the health and social sectors and other areas of infrastructures and support, eliminating legal boundaries to overtime maximum volumes and cancelling or modifying entitlements for vacations, permits, maximizing working hours and rest and leave for training. Training and repurposing the health workforce whose regular healthcare facility has been cancelled to join different aspects of COVID-19 response depending on already existing skill and training capacities. Develop specific phone line and digital interface to support the medical COVID-19 diagnosis for occupational risk support such as psychological support, and to relocate the healthcare worker across the regions according to the healthcare need as planned on voluntary basis. Strategy action 3 is to ensure adequate supply to support the surge in demand, and there are 4 key components within these actions. So for the first component, there may be supply chain problems.
Dr. Ang, are you there?
Yeah, again? Can you hear me now?
Okay, you're back.
Yeah, I don't know, it's just automatically a mute. I didn't click on anything, yeah, I don't know what happened. All right, so for the first component, there may be supply chain problems for essential medicines and health technologies due to the slowdown of productions and bottleneck in the distribution processes amid these pandemics. Some countries are banning parallel export and putting restrictions on exports by national manufacturers. This is limiting the availability of products available for the procurements and may put existing contract at risk. So one option is to regulate and promote local productions of supply with quality controls, hand sanitizers, cleaning and surface disinfectants. Products can be produced by alcoholic beverage companies, laboratories, community and hospital pharmacies. PPE can be produced by textile and plastic producing company, and they are doing so in some countries. And car manufacturers has been repurposed to produce and repair mechanical ventilators with the support of various industry and 3D printing. For the second component is to assure the flexibility and acquisitions clarity, more straightforward procurement processes are needed. Also, quality control mechanisms should be in place to avoid the counterfeiting and low quality products. It should remain that case that all medicine and health products supplied during an emergency should comply with existing national quality standard. When capacity is limited, it is acceptable if the product can be demonstrated to comply with the external quality standard. The World Health Organizations provided technical guidelines on biological standardizations to the national regulatory authorities of non-vaccine producing countries when dealing with the pandemic, influenza emergency, and this guidance can be expanded for all medicine, including vaccine and health technology in the case of emergency. To avoid individual holding and price gouging, some countries have actually moved for the central procurement and assure a nationwide supply chain. Some countries also allow each institutions to have their own procurement procedures with coordinations of the processes to mitigate the potential overpricing and unequal distributions of goods. So, sorry. The third component is about to assure that product comply with the technical specifications. The WHO has received multiple reports regarding the falsified in vitro diagnostic and lab reagents for the detections of such coronavirus 2. Even though different solutions can be found to produce the supplies needed, technical specifications need to be followed. Thus, the specific products for emergency should be procured following minimum quality standard and should follow the specifications developed for COVID-19. The technical specifications have been developed for medical devices to be used for COVID-19 response and other online to assist to evaluate the medical products available to orders. So medicine procured for the COVID-19 should also be aligned with the clinical management guidance for the severe acute respiratory infections when COVID-19 is suspected. Regarding the oxygen therapy devices, it's suggested to comply with the recommended technical specifications and guidance. Safe blood supplies are also crucial, and the interim guidance on blood supply management should be provided in response to the pandemic. The fourth component is to define criteria for the usage of particularly limited supply and promote their applications. The rational use of supply is required to avoid the wasting resources, and there is also a guidance on the rational use, and the link of these documents is listed in this slide. So here is a country experience to create the surge capacity for the supplies, centralizing the purchase and supplies of medicine and medical products, and if needed, establishing a set of prioritization criteria for its prescriptions, repurposing the national industrial for the self-productions of medical products and protective devices, repurposing the military-owned chemistry industry to produce disinfectants and other goods or devices as needed, commanding the military pharmacies if needed to prepare the medical products or drug of common use that may be available in the pharmacies, proactively putting the out cost to private companies who can make the product seems essentials for the response, such as the diagnostic PPE, hand sanitizer, or setting up online facilities where company can sign up to indicate what they can produce. Suspending the compliance on a timely limited basis with a high quality standard for necessary goods, such as masks, providing they comply with the medical safety standard, or relaxing public procurement laws and procedures to allow for fast acquisitions of such goods, empowering the drug authorities to set the prices of the drugs and medical products that are not subject to medical prescriptions, as well as other products that may be needed for health protections, and establish national and regional reserve stock for the medicine and PPE. Establish the limit on the prescribed and over-the-counter medicines that patients can retrieve from pharmacies based on the patient's previous or usual consumption patterns, obliging all companies that produce or may have stock of relevant goods for the COVID-19 response to notify the regions the level of the stock to the central government, renegotiate and redefine the cleaning and security service contracts, local productions and hand sanitizer in the community and hospital pharmacies, and productions of disinfectant in the perfume factory. These are the practice in some of the countries. Let's go to proceed with the last strategic actions. This is to focus on the system to manage and align the policy to merge the surge in demand, and it has 5 key elements. So the first one is to plan and define early the change of command at the national, regional, and institutional levels to activate the surge capacity. At each level, a crisis coordination team should be appointed to develop and manage the acute and intensive care surge plan as an integrated part of the overall national governance of the COVID-19 response. Recruitment of the adequate leadership is crucial. Leadership ability, clinical, technical, institutional, and network knowledge are skills that should be considered, as well as total availabilities. Such coordination team should centralize all the clinical and logistic information, preferably within a dashboard. An important role for the search coordination team is the coordination of the region-wide capacities planning and management. Since the different localities may experience surges at different times, regional and national coordination efforts can distribute patients or healthcare workers to manage the capacities and to give the overstretched services some relief. Likewise, coordination team can redistribute available or purchase diagnostic tests, PPE, or ventilator according to the healthcare need across or within the region. Coordination team should continue and be permanently available to the different coordinations and promote the daily briefing and incorporating the feedback and amending the contingency plan as well. So for the second component is to develop the internal management arrangement at the facility levels. The healthcare organizations will need an integrated internal incident management team functioning 7 days a week and which has strong links to other organizations, local authorities, and very relevant regional government. These teams are a key to speeding up the information sharing and decision making and can comply healthcare workers from all medical specialties involved in the COVID-19 response, such as emergency unit, ambulance services, internal medicines, intensive care, microbiology, preventive medicine, and occupational health department. So understand that difficult choices need to be and are being made in the healthcare organization, specifically regarding the provision of ICU treatments. Consider establishing a local ethic committees to either complement or take the place of any guidance from a higher level. This is important to ensuring that individual healthcare workers are not making this decision on their own, and strengthening downstream communications with primary care and social care providers is critical in order to support optimized service delivery modalities. So too is necessary to ensure that patients' family are informed at all the decisions. The third component is to rapidly adjust the purchasing arrangement to enable activations of such capacities. The existing contracting and payment mechanism will need to be reviewed and adjusted to create a supportive financial environment for the healthcare organizations. Greater financial flexibilities enables healthcare organizations to rapidly reprofile the services, initiate the new service modalities such as remote work solutions, and to manage stock out of the clear supplies. Contracting private sector's providers should be considered to increase the search capacities to the maximum. Retrospective volume-related placement methods, such as case-based or fees for service and contracts, should be replaced temporarily with prospective payments. For instance, for salaries, budgets, capitations, and adequate pre-funding to frontline should be granted to support timely preparations. Payment should cover necessary costs without making profit to secure the financial sustainability of the response. Proof of the expenses should be required from the healthcare workers without adding an unnecessary administrative burdens to ensure transparency for the public spending. The fourth component is to activate the search capacity for the generations, approval, and rollout of any essential evidence to guide the clinical management. This requires a dedicated team, regulatory oversight, and good data management. Good oversight is key to ensuring this is part of any such capacities, response, and planning. This also includes ensuring that ethical issues are given due considerations in any prudential clinical trials undertaken during the emergency as part of the response. The fifth component is to support the providers in to adjust priority setting and difficult decisions. In the advanced phase of community transmissions, ICU may be saturated and the usual standard of care may no longer be realistic. Given the current and projected case number, there are already insufficient number of ICU beds and medical equipment in many healthcare settings across the world. In the case of respiratory equipment, it is not just the absolute number, but the fact that some COVID-19 patients require weeks of ventilation support, where in other cases, support will be for a more limited time. Based on the availability in one of the countries, estimated suggests that a single ventilator will need to serve between 1.4 to 31 patients. It is essential to support healthcare workers in any difficult clinical decisions they need to make in these situations, whether on a single patient basis or more collectively, So frontline healthcare worker must be supported when having to prepare and trigger revised guidelines and clinical decision criteria for prioritizing limited resources in the advance of phases of community transmissions. The professional associations can provide helpful general guidelines on prioritizations admission criteria, with each facility adjusting on its own of saturations. This may involve setting up a stricter criteria for ICU admissions using objective criteria. Adequate protocol should also be available for limiting life support treatment, which may require support from a hospital healthcare ethics committees. Finally, assisting recommendation for exclusion criteria in the events of mass casualty events can also be revised and applied in the case of oversaturations. Fundamental disaster management protocols can be considered by the healthcare organizations to adapt to the surge. Finally, health system policy introduced for any of these areas must be flexible. The COVID-19 pandemic is not static, neither in terms of this disease itself nor the health system actions which it necessitates. Ongoing problem solving and quickly adaptable system dynamics will therefore be key to effectively managing the surge capacity in all contexts. These are the aspirants to create a surge capacity for the systems. Establishing a regional coordinations of capacities. In one of the countries, Regional Coordinations Committee has been established, chaired by the Regional Minister of Health and comprising representatives from the different medical specialties, including the emergency units, ambulance, internal medicine, ICU, preventive medicine, and occupational health departments. Establishing a coordinations mechanism led by the central states to consult the regional governments on their regional needs. Putting all public administration civil health authorities across the national territory under the direct commands of the Minister of Health, and while keeping the management and coordinations functions at the region level, and established emergency purchasing arrangements, such as allowing regions to make contract with the private hospital that do not have the national accreditations. Establish an emergency government arrangement to take over the healthcare worker and equipment of public health services, or take over the management of public health, private health services. Develop the COVID-19 ICU network to manage the surge of patients requiring critical care, and establish a single coordinations command for public and the private health system, which entails creating a centralized functions. Develop a hierarchy and graded hospital network for the first COVID-19 cases, and following this with the selected hospital or buildings which has been dedicated for the COVID-19 cases. Establish work groups in public and private hospital, which included representatives of all relevant medical specialties to speed up the decision making and information sharing. Obliging the regional health authority to share with the Ministry of Health daily a set of epidemiological healthcare capacity, such as ICU, admitted patients, and human resource indicators, which are numbers of intensive medicine doctors and anesthesiologists and resuscitation specialists, including a 4th to 5th year resident doctors, as well as the need for the mask and diagnostic kit by filling in the specific tables. The COVID-19 pandemic is creating unprecedented stresses on the hospital and healthcare system around the groups. So hospital, healthcare system, and regions need to urgently address their resources, identify potential bottlenecks, and create strategy for increasing the surge capacities and resources needed to care for the patients with the virus. In order to function appropriately, the organization needs space, staff, supply, and proper system. So bottleneck or gaps in any of these four can significantly limit the number of patients receiving proper care. The number of ICU beds, critical care nurses, respiratory therapists, and ventilators are limited in the healthcare organizations. Therefore, meeting the needs of such capacity will require out-of-the-box thinking with creative and nimble strategy for adapting, substituting, conserving, reusing, and relocating equipment, supply, and staff. as well as robust system by those outside the health system to address the regulatory, supply chain, and other barriers. So this webinar presented a list of strategy for creating the such capacity based on the review of international guidelines and literatures on the experience during the past outbreak and current COVID-19 pandemic. The guidelines also provide links to varieties of user-friendly tools that allow decision makers at all levels in the hospital and healthcare system to estimate current capacity and rapidly explore the strategy to increasing it. So thank you very much.
Thank you, Dr. Ng, for a very thorough presentations for infection control perspective and also from the surcharge capacity perspective. So we will proceed with the Q&A sessions. I will do it in Bahasa and I will translate it to you in English.
Sure.
So thank you. Terima kasih Dr. Ng untuk presentasinya yang sangat lengkap sekali mengenai bagaimana kita melakukan pencegahan terhadap atau tata laksana COVID dilihat dari sisi pencegahan infeksi dan juga tata laksana COVID dilihat dari search capacity, juga dilihat dari berbagai skenario yang ada dan juga contoh-contoh yang beliau berikan di beberapa negara. Kita akan buka termin pertanyaan. Mungkin kita buka termin pertama dulu dengan 3 pertanyaan. Untuk yang ingin mengajukan pertanyaan, boleh dalam bahasa Indonesia, nanti akan kami terjemahkan ke dalam bahasa Inggris kalau mau mengajukan ke Dr. Ng. Kalau mau ke Dr. Bambang, monggo silahkan langsung dengan bahasa Indonesia. Silahkan kami buka termin pertanyaan untuk 3 penanya pertama. Ada yang mau bertanya kah? Ya. Ini ada di chat. Silahkan bisa raise hand atau bisa ditulis di chat juga kalau ada yang mau. Ada?
Izin dok, dari Bapak Yuwono Adi Iswanto, ini raise hand. Mungkin bisa di-unmute Pak? Pak Yuwono?
Pak Yuwono.
Siap.
Ya,
siap.
sudah di-unmute.
Silakan.
Silakan Pak Yuwono.
Ya, terima kasih Bu. Ya, saya ingin bertanya terkait tentang rumah sakit jiwa ya Bu ya. Kebetulan saya kan bekerja di rumah sakit jiwa. Saya ingin barangkali ada guideline atau strategi untuk kami di rumah sakit jiwa dalam penanganan COVID. Karena kan kalau pasien jiwa datang itu dalam keadaan akut, ngamuk-ngamuk kan susah Bu kita untuk untuk screening segala macamnya itu Bu. Barangkali ada guideline atau strategi apa untuk penanganan COVID pada pasien gangguan jiwa. Terima kasih.
Oke, kita tampung dulu mungkin pertanyaannya baru nanti kita jawab. Oke, pertanyaan berikutnya, yang kedua. Ada yang mau bertanya? Oke.
Saya Bu Dini.
Silakan, Dr. Hanum.
Ya, terima kasih Miss dari paparan tadi, apakah ada ini ya dalam kapasitas untuk mengantisipasi surge capacity ini, apakah diperlukan adanya strategi untuk sharing resources antar rumah sakit? Apakah itu bisa dijadikan salah satu strategi? Artinya sharing resources bisa dalam arti pengaturan rujukan pasien begitu ya, sharing untuk memisah-misahkan pasien dengan berdasarkan status kondisi mediknya misalnya seperti itu, sehingga beberapa rumah sakit mungkin akan fokus pada pelayanan khusus COVID dengan grade tertentu, tetapi rumah sakit yang lain dengan grade yang lain. Apakah itu bisa dijadikan strategi ya untuk menghadapi surge capacity? Ini untuk kita terapkan di Indonesia ya terutama. Terima kasih Dr. Dini.
Baik dok. Penanya terakhir dari termin pertama.
Izin Dr. Dini, ini ada yang bertanya melalui private message ke saya nih.
Silakan.
Ya, jadi ini dari Pak Isman Ramadi. Dia konteksnya adalah puskesmas. Jadi di puskesmas, triase, ruang diagnosa COVID-19 dan pengambilan swab di luar gedung. Jadi APD di dalam gedung selain poligigi dan UGD itu sebaiknya menggunakan apa? Gitu dok, teknikal pertanyaannya.
Oke. Terima kasih. Kita akan mulai dari pertanyaan pertama dari Pak Yono tadi. Terima kasih. So all the question will go to Dr. Eng. So Dr. Eng, there's 3 questions for you.
Okay.
So the first will be, do you have any experience for patient with mental disorders? So like mental disorders hospital. So what is the COVID prevention or for management for the mental health or mental disorders hospital? Do you have any experience in that you could share to us?
Actually, I haven't visited any mental health hospital, but what I heard is like, you mean the precautions, right? I mean, what should we do? Because the mental health patients will not be able to wear the mask all the time, right?
Yes,
This is what I heard from the lessons learned from some of the hospital in some countries. What they are doing, that they can only do the maximum if the patients they couldn't comply, then the healthcare worker will need to do the precautions, a strict precaution by themselves. So they can't force the patient. I mean, the patient don't do it. It's not to say that they don't want to do it, just they couldn't do it. So that we heard is when we asked about that, they say that we just have to follow whatever precautions that we have to follow. We have to be strict. So we have to wear masks all the time. We have to wear PPE all the time just to protect ourselves. This is what I learned from the countries. Yeah.
Okay. So, Pak Yono, jawabannya dari Dr. Eng, kebetulan beliau tidak ada pengalaman secara pribadi, tapi beliau kenal dengan orang-orang yang memberikan informasi. Jadi yang dicoba di China adalah mencoba membuat pasien itu mampu menggunakan PPE atau APD semampunya. Artinya kita coba bahwa mereka akan tetap memakai masker, misalnya walaupun mereka dalam kondisi yang sedang berontak atau sedang tidak bisa ditangani, tapi setidaknya mereka menggunakan masker dan mungkin APD lain yang diperlukan, mungkin face shield atau yang lain gitu. Tapi mereka mencobanya seperti itu kira-kira. Ada tanggapan, Dok, mungkin?
Maaf, saya perawat sebenarnya. Memang seperti itu yang kami kerjakan, Bu, di rumah sakit kami. Jadi memang pasien, saya kira mungkin ada guideline atau seperti apa di sana. Ya sementara ini kami melaksanakan seperti itu. Jadi pasien dengan gangguan jiwa kita bekali masker, walaupun sering dibuang juga, jadi sering hilang juga seperti itu. Ya, jadi untuk petugas di IGD memang kita akhirnya tadi PPE-nya kita kuatin di situ. Ya, sementara seperti itu kami berjalan, berarti ya sama aja dengan yang di luar sana, begitu. Terima kasih.
Oke, saya coba tanya lagi, beliau ada guidelines atau tidak ya? Dr. Eng, do you have any guidelines for a mental disorder hospital that they could use in Indonesia, or maybe from the WHO?
Do have something, but it's not. I don't know anything about pertaining to behavioral science, like mental health. But they do say that if you realize that the patients could not follow, I mean, just not for mental health, then you have to follow the very strict precautions just to protect yourself. But I'll try to search for it. If I have anything, then I'll share with you. Then you can share with them. I'll try to see whether there's something in the WHO.
Okay, thank you very much. Pak Yuwono, beliau akan mencoba mencari guidelines dari WHO atau mungkin contoh dari beberapa negara lain. Nanti kalau sudah ada, mungkin beliau akan kirimkan ke saya nanti, atau saya juga akan share ke Kemenkes juga dan ke Pak Yuwono juga nanti.
Oke, siap. Terima kasih, Bu. Terima kasih atas jawabannya.
Sami-sami. So the second question will be from Dr. Hanum. Dr. Hanum will be the Director for Quality in Ministry of Health, Indonesian Ministry of Health. So she was asking whether in terms of sharing resources, so in terms of like staff and then like medical conditions, maybe we can like stipulate one hospital is specific for COVID and other hospital is for non-COVID patients. So in terms of sharing resources in between hospitals, so it could, related staff, it could relate to the medical devices, it could relate to the medical conditions and other things. Would it be a very good strategy for Indonesia, from your point of view, in this surcharge capacity strategy?
Sharing the resources, depending what you share, I mean, there should be a policy and procedure in place to make sure the patients, the staff or the equipment are safe to be used in individual facilities. Because if you're sharing the equipments or any resources, means that both hospitals they share the same, like they do have COVID-19 cases. But one my suggestion is like if I mean the hospital or the Ministry of Health, they do need to develop some of the procedures to make sure there is proper disinfections, cleaning strategies, or how they make sure the staff is actually safe to be used. I mean, especially the competency, whether they are really safe to work in the different settings. I mean, this is what I can suggest. I mean, I hope I answer your questions.
Okay. So what do you think about leveling? I mean, like the referral hospital, do you think it would be a good strategy for surge capacity?
Referral hospital, you mean the resources that you, the sharing between the referral hospital?
Yes.
Referral hospital means what type of is equipment, staffing, and everything?
Yeah.
Okay.
So we have like in Indonesia, we have like 25 or 24 referral hospitals, top referral hospitals. So maybe they're wondering if they could share some resources because, you know, some people, you know, probably good at this point at this hospital and the other, yeah, something like that. So what about the sharing decisions? What do you think about that?
They right now I cannot just talk about referral hospital. I know some of the hospital, they are lacking of like ICU, intensive care staff. So what they have done is like they give the training, they provide the training, they do the competency, whether it's a referral hospital or not the referral hospital. But some of the staff, they are so skilled. I mean, they work in one hospital and then you move them to another hospital, it will be a challenge. So what they do is because of a lack of resources, they should be like properly trained to make sure they are really skilled, they are competent they are comfortable to work in another hospital, because it's very stressful. You move from one hospital to another hospital. That is talking about staffing. I mean, equipment's the same. I mean, I haven't heard people really sharing equipments, but I heard people that's sharing the staffing between the hospital.
Okay. I'm trying to share to Dr. Hanum. Jadi dok, kalau mereka, karena memang mereka untuk melakukan sharing itu persyaratannya biasanya cukup ketat, jadi harus ada policy on policy-nya. Terutama kalau untuk terkait staffing itu biasanya terkait dengan kompetensi. Jadi apakah kompetensi yang memang dimiliki oleh orang ini bisa dipakai oleh orang di tempat lain. Dan kemudian kalau untuk resources misalnya equipment, apakah proses DTT-nya atau desinfeksi tingkat tingginya itu bisa dilakukan dengan baik di antara perjalanan misalnya, atau di antara proses peminjaman misalnya, seperti itu. Nah, kemudian kalau untuk referral penetapan secara rumah sakit secara level, misalnya apakah rumah sakit ini menerima COVID dan yang lainnya tidak COVID, menurut dia itu masih lebih memungkinkan. Tapi kalau sharing resources dari sisi staff atau dari sisi medical equipment, menurut beliau itu betul-betul harus dibuat polisinya supaya tidak mengganggu satu unit atau satu pelaksanaan unit COVID yang sudah berjalan di satu tempat ini gitu. Jadi juga terkait tadi keamanan, juga terkait kompetensi, dan juga keamanan juga terkait dengan proses desinfeksinya untuk alat medis. Bagaimana dok? Ada tanggapan?
Cukup saya kira begini. Mungkin nambah sedikit ya. Sekarang ini kaitannya dengan SDM ya, human resources gitu. Jadi pada saat surge capacity ini kita tidak hanya berhadapan dengan kuantitas, tetapi juga secara kualitas. Jadi bagaimana misalnya saja ruangan-ruangan atau unit-unit yang memerlukan kualifikasi dan kompetensi khusus tentang ICU gitu ya. Bagaimana sulitnya kita mendapatkan intensivis gitu ya. Dokter termasuk perawat-perawat yang memang diperlukan skill tertentu untuk menangani unit-unit yang high risk ini. Jadi ini tidak hanya sekedar jumlah gitu ya, tetapi kualitas. Ini dari Miss Eng mungkin bisa memberikan tambahan ini wacana bagaimana untuk surge capacity-nya.
Okay. So, Dr. Eng, this is related to the staff, especially for the intensivist, for the intensive care unit. So, for the intensivist and also for the intensivist nurse, which is usually the numbers is very limited in Indonesia. So, would it be good if we could share this staff or this competency to some of the hospital in Indonesia, despite of having them focus on one hospital?
Yeah, I mean, this is what I've done. I've seen in one of the countries in the Middle East that they have a limited number of ICU nurses and then ICU doctors. So what they do is they have a pool of ICU doctors and nurses. They are highly skilled, and then they continue to train them. So they will be deployed to a setting that really need them, instead of just like scattered in individual hospital. That most probably some of hospitals they don't actually need them, but some of hospitals actually. So they collect a pool of the resources with the skilled staff, and then they deploy them as necessary to the different hospitals.
Okay.
That's a good strategy. Yeah.
Thank you. So jadi yang jago-jago ini, Dokter Hanum, kita latih. Kita latih, kemudian kalau nanti mereka sudah pinter, mereka akan bisa di-deploy ke rumah sakit lain yang diperlukan. Jadi metode ini menurut Dr. Eng dipakai di beberapa negara di United Arab Emirates. Jadi sangat bisa dilakukan, tapi dengan training. Oke. Suara saya cukup jelas, Dok? Atau tadi kayaknya sempat putus-putus ya? Sedikit.
Cukup, Dokter Dini. Terima kasih.
Okay, thank you. So the third question goes also to Dr. Eng. So they would like to know, this is the primary healthcare facilities. So they only have limited kind of services, and they already did all the screening outside of the health facilities. And then this is like the appropriate PPE for the inside of the facility. So what do you suggest they have for a primary care of healthcare facilities as a PPE standards?
I mean, for the PPE, as long as they follow whatever infection control is required, whatever the requirement, that will be sufficient. What I would do is the primary healthcare centers, because they are actually the initial point for the patients actually to come in. So I would say that they should strengthen their triage criteria. If they already have, that would be good. But the thing is, now we want to try to limit the entries of any COVID cases. I mean, not just COVID cases, can be any highly consequence infection disease cases. So that if PPE, they just have to follow. If they just encounter a patient, they are not very sure, what I would suggest is they wear the full PPE, as like the patient is coughing and then they have aerosol generating, because they already have been a report to say that it can be transmitted by airborne. So that is the one that I would suggest. If you're not sure, go for the higher level, then go for the lower level. So, but the triage procedure need to be really strict, because you do not want to have one get into the facility and start to transmit to everybody.
Okay, thank you. So, mohon maaf tadi Mbak Ami, jawabannya adalah PPI itu dilakukan berdasarkan level. Jadi ada level 1, level 2, dan level 3. Jadi tergantung dari proses screening yang dilakukan oleh puskesmas ini. Kira-kira dari screening dari puskesmas ini hasilnya lebih banyak menggunakan level PPI yang mana gitu. Apakah level PPI 1, 2, atau 3. Jadi tidak bisa dijawab secara letterlock gitu, tegas, tapi tergantung dari jenis screening yang dilakukan, apakah memang yang diperlukan itu level 1, level 2, atau level 3. Kira-kira seperti itu. Dr. Ami.
Ya, baik, makasih. Seperti ini ya, jadi kontekstual sekali ya intinya, pemilihan APD-nya. Mungkin untuk puskesmas yang tidak ada rawatan COVID ya, mungkin tidak akan berpikir sampai level 3 ya.
Iya.
Kita lihat hasil screeningnya bagaimana, apakah 1 atau 2. Mungkin tadi Pak Isman mudah-mudahan sudah menjawab pertanyaannya. Terima kasih Dr. Dini.
Terima kasih Pak, juga Dr. Ami. Ada pertanyaan berikutnya untuk Dr. Bambang. Ini bagaimana pelaporan IKP, Dok, terkait dengan masa pandemi COVID ini? Kira-kira laporan IKP yang seperti apa yang harus kita lakukan dan kapan?
Iya, terima kasih pertanyaannya. Ya, seperti tadi ya, pelaporan IKP pada saat pandemi COVID ini mengalami penurunan. Jadi untuk nasional Indonesia, kita juga mengalami penurunan laporan IKP. Tapi ternyata di seluruh dunia juga terdapat penurunan pelaporan IKP. Tetapi sebetulnya kita tidak boleh mengendorkan pelaporan IKP ini. Jadi pelaporan IKP harus tetap kita laporkan, apalagi di masa pandemi, karena justru di masa pandemi ini pelaporan IKP-nya mungkin khusus mengenai COVID kan, kita bisa banyak belajar dari laporan-laporan IKP tersebut. Dan kita sudah memperbaiki sistem pelaporan IKP di Kemkes ini dengan membuat suatu pelaporan nanti secara online ya. Jadi dengan demikian akan lebih mempermudah bagi para fasilitas kesehatan untuk melakukan pelaporan IKP. Kami baru saja menyelesaikan survei untuk pelaporan ini pada bulan November yang lalu. Ya, nanti setelah pelaporan kita siap, moga-moga sistem yang baru ini tidak berbeda sih sebetulnya dengan yang lama. Sistem pelaporan yang baru ini akan lebih mempermudah bagi para Fasiankes untuk memberikan masukan kepada kami, untuk nanti kami juga bisa memberikan kembali kepada para Fasiankes solusi-solusi apa kira-kira pada masa COVID ini. Kurang lebih itu mungkin Dr. Dini yang bisa saya jawab. Terima kasih.
Oke, kita lanjut lagi sekarang ke Dr. Eng. Pertanyaannya, Dr. Eng, there's a question from Albras Hospital Batam from the director, Dr. Widya Putri, is asking whether the use of coverall, the jumpsuit, is a requirement PPE for COVID for managing the patient inpatient COVID in as per WHO standards.
No, coverall is not mandatory. As long as you wear whatever is like, you have to wear facial when there is aerosol generating, you wear N95 mask, you wear proper isolation gown that is fluid resistant, you wear gown, and then if there is exposures to the body fluid exposure to the food or whatever, you wear a food cover. I mean that's required. Coverall is not a mandatory. They didn't say that you must wear coverall. There's some countries they are wearing, like in Europe, most of the countries they are wearing it because most probably feel that is really productive, but otherwise that is not a requirement. It's not mandatory by the WHO.
Oke, thank you. Jadi untuk Dr. Widya, jawabannya ini tidak mandatori ya dok dari sisi WHO. Jadi ini mungkin lebih hanya untuk kenyamanan dari petugas saja gitu atau kenyamanan dari healthcare worker saja, tapi tidak mandatori secara WHO dan menurut beliau di beberapa negara seperti Eropa juga tidak semuanya memakai coverall atau hazmat ini. Jadi mungkin itu bisa jadi pandangan juga untuk penanganan kita di rumah sakit, bagaimana apakah memang kita harus memakai hazmat atau tidak. Karena memang pakai hazmat itu panas ya dan tentunya nggak bisa lebih dari 4 jam kayaknya. Lebih dari 4 jam itu selain gombios juga dehidrasi. Jadi ini rasanya jawaban ini cukup menenangkan bahwa kita memang mungkin tidak bisa memakai hazmat untuk jangka waktu yang terlalu lama. Kecuali kalau memang diperlukan. Ya. Okay, and this goes to another question to Dr. Eng. Should we separate the area for radiology services from patient with COVID-19, or is enough just to do the disinfection area in between patients?
Whatever I shared just now, that is a practice that have been implemented in some countries. As long as you have a policy and procedure that can properly segregate or specifically tell people that you have disinfected area for the next patients, whether it's COVID or non-COVID patients, that will be sufficient. As long as at the end, we just want to make sure that patients are safe. So whether you have if your resources allowed, you can have a segregated area. But if not, then you can just disinfect in between patients. Yeah, it's okay. Yep.
Thank you. So untuk Dr. Maria Dewi Indrawati, jadi boleh disinfeksi di antara pasien saja, tidak usah punya area terpisah. Itu sudah cukup asal kita menggunakan memang zat-zat yang desinfektan yang memang menjadi rujukan dari WHO atau kalau buat sendiri juga bisa sih sebenarnya, selama ini banyak saya lihat. Cuma tidak perlu memiliki area yang terpisah untuk radiologi. And this is another questions relating to the hazmats and coverall jumpsuits, Dr. Eng. This is very interesting questions. How are you going to assure, especially the doctors, that they don't need to use the jumpsuit or the coverall? It's sometimes we use it in order to the convenience of our staff. But how do you assure them that it's not needed to manage the COVID-19 patients?
I mean, we often tell them they have to base on the science, what WHO have published, that we follow them. I mean, even though you wear a coverall, does not mean that you will not self-contaminate yourself or contaminate the others. Sometimes the more you wear, the more you will contamination. So the risk of contaminations will be there. So as long as you follow the proper donning and doffing and the proper PPE, I believe, I mean, that is what my suggestions, that it will be enough to cover, to protect you and the patients and the others, instead of wearing a coverall, because sometimes you're so comfortable, you're wearing everything, and then it ended up like more contaminations.
Okay, thank you. So untuk Mbak Wiwin, ini jadi intinya adalah menggunakan coverall juga tidak menjamin kita untuk tidak tertular dari COVID. Jadi bagaimana caranya membuat meyakinkan para dokter dan juga tenaga kesehatan bahwa apa yang dipakai itu sudah cukup untuk melindungi mereka. Terutama ini kan memang sifatnya aerosol. Jadi hal-hal seperti itu yang harusnya lebih kita bisa informasikan kepada rumah sakit dan juga kepada dokter, agar mereka mau mengikuti apa yang menjadi kebijakan dari PPI dari rumah sakit kita masing-masing. Yeah. Okay, so yeah.
Sorry. Again, that is based on your Ministry of Health, your local regulations, because some of the countries, they really mandate the coverall. They feel that it's safer. So for us, we can just say that whatever guideline have told us that it's not necessary. But if the countries feel that coverall is safer, I mean, coverall is like a level 4 PPE. Is not before that they used to for the Ebola, because Ebola have a lot of body fluids exposures that coverall might be necessary, because anywhere you can just splash into anywhere. But COVID-19 is not that much. It's just we know it's by droplet and contact, and doesn't release so much of body fluids like Ebola. But Ebola, we go for coverall, the level 4, when the patient is really sick, because they will bleed from everywhere. I mean,
yeah. Thank you, Dr. Ang. So untuk Mbak Wiwin, jadi sekali lagi penularannya adalah aerosol. Jadi memang pasien-pasien ini tidak tidak mempunyai cairan tubuh yang kira-kira bisa menularkan gitu, berbeda dengan Ebola. Kalau Ebola memang penggunaan coverall menjadi sesuatu yang wajib karena memang salah satu penularannya bentuknya adalah tadi gitu, dari cairan tubuh yang ditularkan. Tapi kalau ini karena aerosol, itu semakin meyakinkan bahwa memang itu adalah tentatif, jadi bisa digunakan dan bisa tidak. Oke, kita ganti-ganti ya sekarang ke Dr. Bambang nih. Ada pertanyaan lagi, Dok, untuk tadi laboratorium. Terkait dengan pelaksanaan laboratorium di semasa COVID-19, apakah perlu diubah apakah laboratorium perlu melakukan FMEA untuk perubahan layanan yang ada terkait dengan adanya pemeriksaan PCR dan juga rapid antigen? Silakan, Dok.
Ya, terima kasih kepada Dr. Suwardi.
Dr. Suwardi Winata
dari Puskesmas Muara Jawa Kutai. Ya, betul, Dok. Jadi sesuai dengan definisi dari patient safety adalah suatu proses yang menjamin bahwa sesedikit mungkin cedera yang bisa kita berikan pada pasien. Jadi pada masa COVID ini tentunya kita bisa memperbaiki layanan kita termasuk di laboratorium ataupun di fasilitas yang lain ya, di rumah sakit maupun di UTD maupun di puskesmas juga kita mencari kemungkinan adverse event dengan melalui FMEA. Dengan FMEA tadi kita mencari apa saja proses yang kita lakukan dan subprosesnya. Nah, dari subproses tersebut the devils are there gitu ya. Jadi kemungkinan kesalahan itu biasanya ada di subproses tersebut. Jadi dengan melakukan FMEA melalui proses dan subproses, kita bisa memperbaiki layanan kita pada semua vaskes termasuk laboratorium. Apakah ada alur pelayanan yang perlu kita rubah atau mungkin juga sudah baik jadi tidak perlu kita rubah. Ya, kurang lebih itu jawabannya. Terima kasih.
Ya, gimana Dokter Sunardi? Mungkin bisa dijawab lagi dari chatnya nanti. Kita lanjut lagi sekarang ke Dr. Eng. So Dr. Eng, someone who's from Borneo or from Kalimantan here, he's asking about, ini Dr. Ivan Haryadi ya Dok, dari Dinkes Kaltim. Is there any different guidelines for labor and delivery? And also, what is the process to disinfect the operating room in between patients?
There is, I mean, guideline apply the same for the operating room, whether it's if whether it's a labor delivery or operating rooms. I haven't encountered anything about for the labor delivery. And the operating room also, you should follow how to disinfect. I mean, especially for the equipments. I know in the operating room there are a lot of equipment, so everything how to disinfect, it should be following the manufacturer instructions for use or manufacturer's recommendations. But otherwise, there is no specific guidelines. That's mainly for the labor delivery or operating rooms. But basically, the strategy remain the same, the recommendation remain the same. In WHO, they say that you have to disinfect with alcohol or chlorine-based disinfectant. That is the one that so far is effective against COVID-19. But again, you have to go back to your manufacturer because a lot of equipment, most probably, they are not compatible with alcohol, they are not compatible with chlorine. So that is the recommendations that the WHO have extended.
Thank you, Dok. So, Dr. Ivan, kalau untuk guidelines-nya sendiri untuk kamar operasi dan juga untuk proses melahirkan itu tidak ada yang berbeda, Dok. Jadi sama saja dengan apa yang sudah ada sekarang. Cuma kalau pertanyaan dokter mengenai apakah rapid reaktif perlu dirujuk, saya rasa itu mengacu kepada kemampuan dari institusi kita masing-masing. Apakah memang kita mampu laksana atau tidak. Jadi kalau memang tidak mampu laksana, mungkin harus kita rujuk ke vaskes yang lebih tinggi. Juga untuk situ operasi ya, dokter tanya di sini. Saya rasa itu tergantung dari kebijakan institusi masing-masing. Jadi kalau untuk penata laksanaan melahirkan sendiri dan pembersihannya, itu tidak ada yang berbeda. Jadi seperti biasa saja, antar pasien operasi memang kita selalu membersihkan ruangannya dan pasti sudah punya standar pencegahan infeksi yang sesuai dengan itu sudah cukup untuk menurut beliau, jadi tidak perlu ada tambahan lagi. Gitu. Ada tambahan mungkin Dr. Ivan, kalau mau bisa lanjut di chat.
Oh ya, makasih Dr. Dini. Jadi memang sering sering jadi permasalahan problem karena dokter ada yang ketakutan dan rumah sakit rujukan juga kadang-kadang nggak mau nerima yang cuma rapid reaktif gitu loh. Terima kasih dokter.
Oke, terima kasih. Kita buka lagi link pertanyaan. Kebetulan pertanyaannya dari chat sudah terjawab semua. Mungkin ada bapak-bapak, ibu-ibu yang mau bertanya. Kalau belum, sebenarnya saya pengen nanya ke Dokter Bambang sih.
Iya kan.
Mau gangguin Dokter Bambang aja, oh salah ya.
Silakan, Dok.
Ini moderatornya Usil, Dok, mohon maaf. Jadi kalau kita melihat presentasi dari dokter tadi, sepertinya leadership itu memegang peranan yang sangat penting atau kepemimpinan memegang peranan yang sangat penting di dalam kasus atau penanganan pandemi COVID-19 di institusi kita masing-masing. Mungkin apa yang menurut dokter menjadi satu hal yang bisa dilakukan oleh para pimpinan rumah sakit, saya yakin yang datang hari ini juga banyak pimpinan rumah sakit. Apa saja sih yang harus mereka tekankan atau mungkin mereka lakukan secara terus-menerus selain dari komunikasi yang tadi dokter sudah sampaikan memang harus kita lakukan terus-menerus. Cuma mengenai juga masalah yang lain yang mungkin dokter bisa share sedikit, mungkin reward atau bagaimana pengaturan jam kerja. Mungkin ada orang yang punya jam kerja jadi lebih banyak karena kompetensinya mungkin lebih cocok untuk COVID. Dan bagaimana juga untuk orang-orang yang tadi kompetensinya ternyata tidak, justru malah kurang gitu loh pada saat COVID ini berlangsung gitu misalnya. Silakan Dok, mungkin bisa sharing sedikit pengalamannya di rumah sakit dokter supaya teman-teman yang ada di dalam chat ini semuanya bisa belajar.
Ya, terima kasih Dokter Dini. Dari WHO itu sebelum ada COVID ini, mereka melihat bahwa kalau nggak salah di tahun 2015, bahwa untuk melaksanakan patient safety ini yang paling utama adalah leadership dan culture. Ya. Jadi memang yang harus utama di sini yaitu tadi leader, apapun masanya, masa COVID atau tidak, leadership dan culture. Dan di masa COVID ini kita dipaksa, dilatih untuk lebih menguatkan hal tersebut ya. Karena langsung kelihatan gitu dampaknya kalau kita leadership dan culture-nya tidak kuat, langsung korban berguguran seperti itu. Nah, jadi di situ. leadership dan culture. Jadi top down, tetapi juga harus mendengarkan dari frontliner seperti tadi. Dan responsiveness. Jadi begitu ada asupan, begitu merasa perlu ada yang dirubah, tentunya bersama-sama dengan tim ya, dengan memperhatikan regulasi-regulasi baik dari WHO maupun dari pemerintah, langsung melakukan tindakan-tindakan dan langsung dicek ya. Jadi mungkin dengan komunikasi yang lebih baik, dengan tidak takut melakukan speak up tentunya, baik dari sisi direksi maupun dari sisi provider nakesnya, karena kita lebih dengarkan nakesnya tadi, frontliner tadi, kemudian ada usulan apa, langsung berikan respons, regulasi ataupun tindakan, dan tentunya tidak ada yang tidak retak. Jadi tentunya mungkin mungkin juga tidak berhasil, nah kita bisa perbaiki lagi gitu, seperti itu. Tapi jangan takut untuk mendapat masukan, mendapat kritikan, dan jangan takut juga untuk melakukan kritik yang baik tentunya untuk selalu perbaikan. Mungkin seperti itu kalau yang bisa saya lihat. Jadi kelihatannya apa yang di COVID ini baik di Indonesia maupun di negara lain masalahnya sama. Jadi penyelesaiannya juga alurnya kurang lebih sama seperti itu. Jadi kita perlu responsiveness, ya, kita perlu maju terus. Apa itu menjawab, Dokter Dini?
Terima kasih, Dr. Bambang. Mungkin from Dr. Eng, can you share your experience in related to the mental health of our staff? Because we know that during this COVID pandemic, the mental health of our staff is, we are struggling with the mental health issues, especially because they have, maybe different hours of different working hours, and then healthcare fatigue and everything. So do you have anything that you would say about that? Or you can share a bit of your experience about that?
I have actually given the presentations on the mental health and psychological support during the patient safety, WHO patient safety in October, I think in September 17 or September 15 to some of the hospitals in Asia Pacific. I can share with you the slide, I don't have a problem. But the thing is, I do agree. People have talking about PPE, people have been talking about they don't have PPE, they're talking about the resources, their lack of the resources, but no one have actually really taken care of the staff mental health. I mean, I don't know about Indonesia, but in so many hospitals in the US, people are getting bullied, the family member attacked because they are thinking that they are the one who actually bring the virus to the communities. And then actually Institute IHI and so many professional organizations, they have actually advertised and published some of the guidance, like psychological PPE. That is one of the things that provided to the facilities that they can use to actually motivate the healthcare workers. How do they actually help them to support them in psychological support? They should have a hotline, they should have a buddy system like I have just discussed. And then they have also come out with something like they have done a survey to several healthcare workers, like 56 healthcare workers, and talking about what they want them, the leadership to hear, to listen, to support them. And then there are 8 elements that actually support them, how do they pass through this difficult time. And then it's quite successful. There are several studies that have say that it's quite successful. I don't have problems. I can share the slide with you, and you can share with the healthcare organizations in Indonesia. It's a very helpful tool, and they find it very helpful because there are so many people that people have encountered really a lot of stress, burnout, and then some of them even committed suicide, and then some of them consume take illegal drugs, other drugs, and then just to make them better. And then that is very sad. I mean, when I look into the studies. So yeah, that has been a big issue, especially now we're going into the second and third wave. So healthcare worker support is really crucial. That's why, I mean, just so we know that we have something in the SQE that the occupational the psychological support is part of the self-help programs that we really need to support our healthcare workers.
Okay. Yep. Thank you. Yeah, Dr. Bambang, silakan.
I would like to ask Dr. Bang about the psychological stress. What is the role of occupational specialist or department in managing and supporting the psychological stress? Or do the GCI or the WHO have written guidelines for what the occupational specialists do? Thank you.
We don't have any guidelines, but we do say that you should have occupational health programs that you address provide the psychological support. At least if a healthcare worker, they need someone to talk to, or if they feel comfortable and they have some concern, they can go to, the occupational health clinics or any of the psychologists to address their concern. So there's actually no guideline that the GCI have written. We just say that you should have something that some people, they have provided programs that to say that we have hotline, you can talk them. But there are 2 or 3 facilities in the Middle East. What I have known, that I have seen, that they have, even the Ministry of Health, they have developed them hotline. Most probably Indonesia you have, like the people can call in because they feel that they are so down, but they don't feel comfortable to talk to the hospital, and especially now they don't want to lose their job. So so that is one of the strategies they have implemented. There are so many out there that the hospital can do it, and I know there is a lot of support that the leadership in the hospital, they have extended. So that is based on you, what you can make, but is based on the need of the hospital, what you have to do. That's why they have done a survey in some of the on the 56 in US, they have done in 56 healthcare workers to ask them, what do you want from us? So then they come up with a summary to say that to listen to us, support us, look at us, and then there are 8 elements that they have put up, like a qualitative what we say, the team that they come out with when they interview the staff. That is what came out. That so there are certain things that the healthcare worker do need support. They are not protected. They feel that they are not protected. They are just very they're just put out there to take care of the stuff, but nobody take care of the mental health. But they're taking of the they have been taken of the physical health because of the PPE, but the mental health wise, this has been not taken care of. But right now I can see WHO has also come out with a lot of mental health things. They have been reinforcing even in the news. So I think slowly right now people are looking into the mental health issues of the healthcare workers. I mean, it's not just a healthcare worker, even the family members.
Thank you.
Thank
So,
you.
jadi Dr. Eng ini pernah berbicara di WHO, di WHO tentang mental health untuk seluruh tenaga kesehatan. Jadi di luar negeri, terutama di Amerika, itu memang menjadi tenaga kesehatan itu bebannya luar biasa, ya. Jadi kalau di rumah dan juga di komunitasnya, mereka itu dikucilkan karena mereka dianggap sebagai orang yang membawa virus COVID-19 dalam komunitasnya. Sementara kalau di dalam mereka sendiri, di dalam bekerja, sebenarnya mereka juga ketakutan. Karena mereka juga takut tertular, gitu ya. Nah, jadi beliau akan memberikan beberapa guidelines yang terkait dengan mental health ini nanti dalam presentasinya akan dikirimkan kepada saya. Dan nanti mudah-mudahan saya bisa lanjutkan juga untuk diberikan kepada seluruh peserta webinar sore ini. Gitu. Kira-kira. Kemudian kita lanjut ke pertanyaan selanjutnya. Di sini, it's also for Dr. Eng. Do you have integrated care pathway for COVID-19?
We don't have, but I think it's an integrated care pathway. I mean, how do you take care of patients?
Yes.
With the no, we don't have it. But I know it's part of the WHO. There is a care pathway that. But again, is how you. I mean, it's based on what you develop in your hospital, because individual setting we have different pathway. So there should not be one size fit all pathway, but for everybody. So we can recommend, I mean, there's different treatment, there are different care plans, there are different everything. But the thing is, it has to be fitted to your hospital. That you have to need a multidisciplinary team to develop the pathway.
Oke. Oh, jadi untuk Dr. Hairul Syahrudin ini jawabannya untuk integrated care pathway itu harus dibuat sesuai dengan kebutuhan rumah sakit masing-masing. Jadi tidak bisa dijadikan satu. Standarnya adalah bagaimana kita tata laksana COVID berdasarkan WHO, Tapi bagaimana menjalankannya itu harus disesuaikan dengan kondisi rumah sakit masing-masing. Jadi kalau mau membuat, bisa dibuat tapi khusus untuk rumah sakit kita sendiri, itu tidak bisa digabungkan dengan rumah sakit lain, gitu. And I've received these questions several times, Dr. Ang. How about the COVID management or the air circulation in the operating theater? Because as we know that the operating theaters is usually using the positive pressure. And with this COVID-19 pandemic, we have to use the negative pressure room. So this is a very frequent question that I received. So I would like to know what is your point of view for this operating theater circulations.
I think there are three, according to the AORN, I think there is Association for Perioperative Nurses, perioperative nurses. They have recommended actually you can use negative pressure, you have used positive pressure. I do have the guideline. I will share with you, and then you can give it to them. There are three recommended guidelines for the COVID-19 patients, what type of setting they can use it.
Okay.
Yeah.
It's very nice of you. Is it different settings? I mean, different room with different settings, or do you combine it together in one room?
They did say that just like a TB patients, like sometimes they just say that you can have it in the positive pressure in the OR, but you need HEPA filters. Otherwise, you have to intubate the patients in a setting with a negative pressure and move the patients to the operating room. So there are different strategies how to manage the patients. There are three strategies, but I couldn't remember the detail. But they do have a guideline from the AORN.
Oh, okay, thank you. Jadi untuk Rumah Sakit Sekar Kamulian ini jawabannya memang walaupun kita pakai positive pressure, kita harus tetap punya HEPA filter kalau memang pasiennya tidak terintubasi. Tapi kalau pasiennya terintubasi sebenarnya bisa disetting dari depan supaya posisinya pasien itu memang sudah terintubasi dan ada seperti kayak kotak gitu kali ya, yang nutupin sehingga saluran udara tersebut atau udara tersebut tidak kemana-mana gitu. Jadi memang betul-betul terpisah begitu dia masuk ruangan itu. Saluran udara yang khusus untuk tekanan negatif tadi itu memang diarahkan ke satu saluran tertentu gitu. Beliau ada guidelines-nya yang akan nanti beliau bagikan kepada kita juga. Jadi nanti insya Allah akan saya sebarkan juga untuk teman-teman di Rumah Sakit Sekar Kamulian. Ya, terima kasih banyak atas pertanyaannya. Ada lagi yang mau bertanya? Ini pertanyaannya bagus-bagus juga, lumayan. Ada lagi, Kak? Oke. Kalau coba ya, saya cek lagi. Sepertinya udah tidak ada yang bertanya. Ya. Sama-sama ini dari Rumah Sakit Sekar Kamulian membalas. Nanti kita berikan ya ininya, guidelines-nya. Oke, kalau dari Kementerian Kesehatan sendiri, khususnya dari Dirjen MAI, mungkin ada yang mau bertanya terkait dengan presentasi Dr. Eng untuk surcharge capacity. Di sini kan surcharge capacity itu ada 4 komponen, yaitu staffing, kemudian space, kemudian supply, dan juga sistem. Tadi Bu Hanum sudah bertanya supply di mana resources dari Dirjen ada yang mau tanya mengenai staffing atau space atau yang lain, karena tadi beliau menyampaikan beberapa strategi, kalau nggak salah ada 4 strategi yang bisa kita pilih untuk searching capacity ini. Ada mungkin dari teman-teman?
Dokter Dini, izin saya.
Makasih Dokter Arya, silakan.
Ya. Terkait dengan search capacity tadi kan yang keempat adalah sistem ya. Saya pernah membaca kalau di Amerika itu kan IOM pernah ada yang disebut dengan krisis standard of care gitu, tapi di tingkat nasional. Jadi pada saat terjadi kondisi pandemi seperti ini di tingkat nasional itu dibuat yang disebut dengan krisis standard of care, di mana nanti akan diturunkan kepada Fasiankes untuk membuat standar of care-nya sesuai dengan tingkat dari Fasiankes itu sendiri. Jadi itu hubungannya tadi pertanyaan dengan sistem. Kemudian yang kedua, di dalam suatu framework terjadinya pandemi itu kan ada namanya konvensional fase, kemudian ada namanya kontingensi, dan kemudian ada namanya krisis. Jadi 3C. Mungkin Dr. Ang bisa menjelaskan 4S tadi hubungannya dengan 3C atau 3 fase tersebut, sehingga kita bisa memperkirakan kapan kita bisa kembali dari kondisi krisis ke kontingensi atau kita sudah masuk pada kondisi yang konvensional. Mungkin itu saja, Dr. Dini. Terima kasih.
Okay, thank you, Dr. Aryati. Dr. Eng, this is a question from Dr. Aryati. So he realized that from the IOM, he learned something from the IOM that in regards of the search capacity in terms of the system. So we have to determine our standard of care, and our standard of care is going to be leveled into three levels. The first will be the conventional one. The second will be the contingency, and the third will be the crisis.
True.
So can you relate what is the connections or what is the relation in between the staffing, space, supplies, and system to this conventional contingency and also this crisis? So when can we move from the conventional to the contingency, and then from contingency to the crisis? And when are we going to move from the crisis to back to the contingency or to the conventional level?
That is based on how you determine your facility. Conventional means that routine. You don't have any emergency. You are doing whatever is currently, you procure the right number of PPE, and then you're using them as routine without any outbreak, without any. So when you come to contingency, means it's like an early stage of outbreak. You have a certain disease, like what I will take the example, like COVID-19 is ongoing. I will not use them, but for initially what I learned from the Ebola is like when they started to have cases, the hospital have cases, they might need to start to put a contingency, like they have to procure more, that they will use it for the number of patients with the Ebola or any of the infectious disease or like right now is COVID-19. You have the PPE, but you need to procure more number to accommodate the increasing number, the resurgence of cases. So that is what is like a contingency. But for the crisis means you have to reuse. You have to plan to reuse. You have to cut down whatever activity you cannot. You have to just keep the PPE for essential use. You cannot use it for another like elective surgeries. That's why when I was talking about the resuming roadmap to the elective surgery, you will never resume the elective surgery if you are in the crisis of standard care. So that is the one that we say. But for the staffing is also, I mean, that is a post system that we say for the PPE. But the thing is, for a staffing itself, then it's also the same. When you have a conventional, normal routine, you have your staff working in the ICU. You don't need to float them. You don't need to put into the other healthcare in the other in the other units, just to help in other medical care. But in the contingency, you will need to put up the plan just in case if you have a patient, you have to open up another unit or alternate care site. You have to deploy these nurses to another care site. Like crisis of care, really, you're short. You don't know what to do anymore. You don't have a skills out, so you have to rely on the Ministry of Health. You have to put the system in place that you have the pool of ICU that you have get help from outside that to come in to help you. That is a crisis of care. That is about the staffing. Supplies the same, like I was just mentioned about the PPE, and then you have another one that is about the what else I missed. I talk about staffing, I talk about system, I talk about supply.
Space.
Okay, the space is the same. When you have crisis of care, you really don't have the space anymore. You have to relocate the patients to another hospital, another countries, and then you might have to put in the alternate care site. Alternate care site can be in the crisis, can be in the contingency. That again, hospital will not work alone. They normally, what I understand is they work with the Ministry of Health. And in the contingency, most probably they will decide, the Ministry of Health will decide that they will allocate one of the sites, just mean the COVID hospital and non-COVID hospital. When during crisis, you really are so short, you cannot even accommodate. You don't have a PPE, you don't have anything. You have to come up with strategies like you involve the private sectors, or you have to maybe get the neighboring countries to get the help that is onto the crisis of care. And then for the conventional, there is a routine like normal. Life is going on just normal. I hope I answer your questions.
Oke. Dr. Aryati, kira-kira masih perlu saya terjemahin nggak? Kayaknya nggak sih ya.
Oke. Satu mungkin Dr. Dini, berapa lama kita bisa melakukan monitoring evaluasi untuk kita sudah bisa kembali dari misalnya tadi krisis ke kontingensi kepada konvensional. Maksud saya kita bisa tahu kita sudah ada di fase ini. Kira-kira kita butuh waktu apakah 2 minggu, 1 bulan atau berapa bulan sehingga kita bisa kita sudah ada di posisi ini. Karena saya pernah baca kalau dari konvensional ke kontingensi itu ada semacam trigger gitu. Trigger yang kita tahu kita sudah di kontingensi, kemudian kontingensi kepada yang krisis itu ada namanya indikator bahwa kita sudah ada di posisi ini. Nah, mungkin Dokter Ang punya nggak itu tools-nya atau indikator yang kita tahu bahwa 4S itu kita sudah kurang, bahwa apa, tapi kan semacam ada suatu indikator kita ada di sini dan berapa lama kita bisa melakukan suatu review atau analisa gitu. Makasih.
Very good question, Dr. Aryati. So, Dr. Aryati was wondering, is there any, do you have any trigger tools or something that you could use as a tools and routine monitoring and evaluations? And when are we going to go from the crisis level to the contingency and from the contingency back to the conventional?
Yes, there is something that I attached in my presentation. If you look at the search planning tool, there are the tool who look into the whole system. That is from WHO. There's a search calculator. Look at the PPE system, staffing, supply, and space. So there are 3 of them. If they're using them, it will trigger you. You went up to the crisis area. It will tell you that you are not in the safe place. Get more PPE. Your space is not enough to accommodate patients. Do something about it. But again, that is just a tool. Again, the processes will be up to you how to. But it will have. This is a trigger. There are 3 tools that I attached in my presentations. That if you click on it, it will link you to the tool, to the site of the tool, that you can download them and use them.
Oke, Dr. Aryati, menurut beliau di presentasinya ada linknya yang nanti bisa terhubung ke sana. Mungkin yang di bawah itu kali Dok, yang di sebelah kanan bawah. Kan biasanya beliau kalau ada di atasnya ada penjelasan, di bawahnya sebelah kanan bawahnya ada kayak resources. Mungkin maksudnya beliau diklik dari situ, nanti akan keluar trigger tools yang beliau pakai. Nanti coba kita lihat kalau dokter nggak bisa dapat infonya, nanti saya hubungi beliau untuk mintakan trigger toolnya.
There are several tools I've attached because they are quite good. What I think that how to evaluate the products, because some products, especially now the COVID-19, so many companies are trying to manufacture a lot of products. That's why I also attach a link that like biological standardizations. There's certain criteria you should meet before you can use the product, just to protect the staff and the patients for the harm from meeting the quality, at least the medical safety quality standard. Because right now we need everything fast, so we just want to make sure that everything is safe. So I have also attached some tools that you can look at it. Then it might be a good help from WHO.
Okay, thank you.
Yeah.
Dr. Aryati, ada tanggapan Dok? Dok? Dr. Aryati? Dok? Oh, beliau sudah sedang off mungkin. Oke, nanti kita lanjut lagi. So I think we have 2 last questions here. The first will be, okay. Saya unmute ya Dok. Oke. Dokter udah bisa. Nah, silakan Dok.
Iya, tadi yang pertanyaan waktunya Dokter Dini yang belum terjawab ya. Berapa lama?
Okay. So Dr. Ang, the question is about the timing. When should we do this trigger tool? Usually, when we should do this in a monitoring and evaluation plan? It's like every 2 weeks or every 1 month or things like that.
That has to be based on your risk assessment. That when you should do it. There is no certain period of time. If you feel that the monitoring, if you feel that there's a need to monitor it every week, then you have to do it. Then if you feel risk assess, there is a decisions of a multidisciplinary team. It should not be based on like a fixed period of time. This is what I can suggest.
Okay.
Yeah.
Jadi seperti itu ya, Dokter Aryati, jawabannya tergantung dari kondisi risk assessment kita di awal. Dari situ kita bisa lakukan, misalnya kalau kita mungkin banyak menerima pasien COVID, ya berarti mungkin masih antara krisis dan kontingensinya itu masih dekat waktunya gitu. Mungkin agak atau justru agak jauh gitu. Jadi kita lihat dari perkalian hasil dari risk assessment kita dari hazard vulnerable analysis-nya berapa gitu angkanya. Sepertinya itu maksudnya beliau. Oke, so kita akan masuk ke 2 pertanyaan terakhir ini. Again, ini untuk dua pembicara ya. Saya ingin dengar pendapatnya. So, what is Dr. Bambang and Dr. Eng point of view about the vaccine? So this is a very good questions, and like everyone needs to know what's in your mind, because it's very important to know that. So please do share some of your experience, maybe in China or something like that. I have no idea.
No, I don't know about China, but in Malaysia, I will tell you that we are still waiting vaccine. We're so happy that we heard the vaccine is coming out. But the thing is, I mean, it's good, but right now, we still need more data to say that. Although we know that there are, we know Pfizer, we know the other one is one Moderna, what we heard from the States. But the thing is, right? I mean, it's always good to have a vaccine, so that we can go back to our new normal. It's not a normal. But the thing is, like, yes, I mean, I don't know what to tell you, but the thing is, this is good. This is the very great news to have a vaccine to be available. But the only thing is, like, the transport is going to be an issue because the vaccine need to be negative 70 degrees, so it's going to pose a very big challenge. So I really hope that everything will be fine, and then we will get our vaccine soon, and then that's all I can say.
Oh, thank you. So kalau Dr. Eng sangat menunggu kehadiran vaksin ini, apapun mereknya, karena walaupun yang terbaik pada saat ini mungkin Pfizer, tapi Pfizer itu juga sulit sekali karena dia harus disimpan di suhu minus 70 derajat. Jadi membawanya pun ke negara masing-masing itu akan sangat sulit. Tapi untuk vaksin lain menurut beliau sangat baik kalau bisa digunakan terlepas dari merek apapun yang kita punya pada saat ini. Silakan Dr. Bambang. Ayo dok.
Ya, kalau personally. Kalau saya personally.
Profesionally dong.
Oh gitu. Jangan terlalu terburu-buru ya. Jadi kita mesti cari evidence base-nya dulu, betul-betul aman seperti itu ya. Ya, yang utama adalah pemutusan rantai kan. Kalau dengan vaksin itu pemutusan rantai bisa, ya oke gitu. Tetapi apa yang sudah kita lakukan sekarang jangan kendor. Artinya distancing dan itu jangan kendor. Itu tetap harus dijalankan ya. Jadi ada vaksin, oke, kita tunggu. Kalau dia betul evidence dan baik, kita lakukan ya. Dan hasilnya juga kita kan juga tidak tahu pasti kan. Artinya kiat-kiat yang sudah terbukti baik ini, distancing, cuci tangan, dan itu semua itu harus kita lakukan. Itu jangan ditinggalkan walaupun sudah ada vaksin seperti itu. Kalau saya sih seperti itu ya. Jadi, vaksin kita tidak menolak, bagus ada vaksin. Tapi ya itu sambil jalan ya. Jangan mengurangi yang lainnya. Itu pendapat saya.
Correct. I agree with what Doctor have said. I mean, even though with the vaccine, we still need to follow the proper precautions because we still don't know. It's still too early to say. We don't have the data itself. Yeah. Although it say that the vaccine is available, is 99.9% or 99.5% is effective, but we still need to follow the proper precautions. Correct. Yeah, I totally agree.
Thank you. So it's very nice having both of you today as our resources for this very good sessions today. Thank you so much, Dr. Eng, and juga terima kasih banyak untuk Dr. Bambang. Untuk beberapa pertanyaan yang mungkin belum terjawab, bisa nanti diajukan ke kami juga. Nanti akan kami lanjutkan ke Dr. Eng, karena memang sesuai dengan perjalanan waktu, insya Allah kita akan menutup acara ini di jam 16.30. Dan 16.30 itu mungkin nanti masih ada beberapa pengarahan lagi dari Ditjen Mai. Jadi sekali lagi terima kasih banyak untuk pembicara kita sore ini, Dr. Bambang dan juga Dr. Eng, juga untuk Dirjen Bu Hanum dan all the team, Dr. Irna, Mbak Evi, Dr. Ami, Dokter Dahlia, Dokter Tiwi, mungkin saya nggak lihat, Dokter Sunarto, banyak sekali semuanya. Terima kasih, dan yang terlebih terima kasih adalah kepada seluruh peserta yang antusiasnya tetap tinggi sampai sore ini dengan pertanyaan yang luar biasa bagus-bagus berdasarkan pengalaman kita semua. Dan tentunya COVID ini memang menjadi suatu pembelajaran yang sangat besar sekali untuk kita. Sejak Februari sampai sekarang kita belajar banyak dari COVID ini. Sekali lagi terima kasih. Mohon maaf kalau ada yang kurang-kurang, ada yang mungkin tidak berkenan. Saya kembalikan kepada Dr. Irna untuk kita lanjutkan untuk acara penutupan. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ya, terima kasih Dr. Dini Handayani yang telah memandu acara pada hari ini dan betapa banyaknya ya ilmu-ilmu dan hal yang memang terkait dengan COVID-19 ini sehingga kita semuanya terbuka gitu ya, bahwa ternyata banyak yang memang luar biasa yang bisa kita gali gitu. Terima kasih juga kepada narasumber kita yang luar biasa, Dr. Bambang Tutuko, dan kemudian very much thank you for Miss Wai Kwam Ang. Jadi terima kasih atas materi-materi yang sudah disampaikan. Maka dengan demikian sebelum ditutup, apakah ada yang ingin disampaikan dari panitia, mungkin Bu Evi? Ada ini atau kita langsung sudah selesai? Sudah ya, baik. Kalau memang sudah, maka dengan demikian
Ibu mungkin dari Ibu Direktur untuk
dari Bu Hanum, mungkin dari Bu Hanum.
Bu Hanum sepertinya ada pertemuan ya dengan Pak Dirjen ya.
Oke.
Ya, sebenarnya ada pertemuan. Baik, mungkin dengan demikian acara webinar tentang tata laksana COVID-19 dari perspektif regulasi keselamatan pasien dan pengendalian infeksi selesai sudah. Terima kasih kepada bapak-bapak dan ibu-ibu peserta webinar yang sudah mengikuti webinar ini sampai sore, dan terima kasih juga memang pertanyaan-pertanyaannya juga sangat-sangat baik gitu ya. Dan sekali lagi terima kasih kepada moderator dan para narasumber, kemudian Ibu Direktur dan semua teman-teman panitia, sehingga acara webinar pada hari ini dapat terselenggara dengan baik. Kami dari panitia juga memohon maaf apabila pada acara ini ada kekurangan yang terjadi pada awal-awal, tapi semoga acara webinar ini dapat memberikan manfaat untuk kita semua ke depannya. Mungkin demikian acara ini selesai dan kami tutup. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Bapak Ibu dipersilakan untuk live, acara sudah selesai.
Bu Amin mungkin
terima kasih Mbak Dini.
Pengumuman yang untuk
indikator nasional.
Indikator nanti Mbak Evi.
Cepetan
nanti. Pamit, makasih Bu Irna, Dr. Dini, Dr. Bambang, Dr. Eng
dan semua.
Thank you.
Terima kasih Dr. Dini, Dr. Bambang, Bu Irna. Kami di sini sudah gelap gulita.
Pamit live ya, Evi.
Ya, kami juga pamit.
Oke, jaga kesehatan ya. Dadah.
Ya. Baik, Bapak Ibu sekalian, saya end meeting. Untuk materi sudah kami upload di link materi. Semuanya sudah ada 3 materi yang ada di link tersebut. Silakan di-download untuk dapat dibagikan kepada sejawat kita yang lain. Itu saja dari kami. Sekali lagi kami pamit.